Yes, thank you speakers for your patience. Sorry for the technical glitch. There's a small power fluctuation and the LED screen got off for some time. Now we are all ready and hope the speakers and the chairpersons are ready for the scientific session to start in few minutes. Thank you for your patience again. HDMI cable.
Fine line going, huh?
అంటే ఫైవ్ లైన్ ఆగిపోతుంది ఖాళీ అని introduce you and then chairpersons వస్తారు.
నేను ఒకసారి ఏంటంటే మురళి గారితో ఇది ఆపరేట్ చేసుకుని అక్కడి నుంచి మాట్లాడతాను.
నేనుంటే నేను స్లైడ్స్ పెట్టాను. So I would like to welcome the chairpersons for today, for Mr. Sai Koti sir, Mr. Ramesh sir and Bhuvneshwar sir, Bhuvneshwari ma'am, please chair the session. I'd like to invite Mr. Sai Koti for today's scientific session as a first speaker. He's a master's in ASLP and certification in executive development program in leadership and change management. XLRI Jamshedpur. He has his expertise in diagnostic audiology, differential diagnosis, counseling, hearing and fitting, client handling and customer relation management. He's successful at developing and improving various verticals with advanced understanding of training needs. He's also a zonal head, Hearing Solutions Private Limited, Visakhapatnam, Andhra Pradesh, India. We welcome Sai Koti sir. Thank you for your expertise.
Thanks for the introduction. I'm no more a zone lead. Good morning, everyone. Am I audible? Yes. So before going to today's session, I would like to ask you all to do a small task. How many of you are students? Please raise your hands, all the students. So I request all the students to please come up and fill the front row chairs. Please get up and come. Fill the front row chairs. Request all the students, please get up from your chairs. Those four rows from the back.
No students. You can use us as students.
Yes.
There are no students.
No. I just want to mobilize them. We'll start. Mobilize them. They're sedimented. Lifelong students, yes.
Yeah, even
Okay. So, thank you ASLPA for inviting me for this speech today. And before going to today's session, so I hope you all have seen the itinerary and you might have a basic idea of what today's session is all about or what I'm going to talk about. So here I'm going to talk only about my pure expertise which I have gained over the years, so which will be very much helpful for all the budding audiologists. So before going to today's session, so I would like to give you a small story which gives us a lead into today's session. So all of you might have heard of Mahabharata, right? Yes? So in a gross, can someone tell what is all Mahabharata about? Okay, someone says war. Sorry? Lifestyle, okay, the way how we need to live, okay. Anyone from students on a gross aspect? Give a chance. So it is very much closely related to our topic today. A path, okay, you say it is a path. Fighting for freedom, okay. Kingdom, okay, kingdom. Okay. Abhimanyu listens to the story, okay. See, basically, if you have ever seen Mahabharata as a scripture, it is more of, they call it as Samvada. See, according to scriptures, we have three types of conversations. One is Samvada, the second one is Jalpavada, and the third one is Vitandavada. Okay. The first one is the mainstream communication wherein both will discuss. That is, there will be a person who is trying to guide someone and there will be a person who has a problem. And they will try to explore, discuss the various things and to get a clarity or to get a path to reach their goal. So in this, there is nothing wrong. They'll only discuss what is correct and what has to be done. And in the second path, that is Jalpavada, where someone tries to explain what is correct, but the other person keeps adamant that whatever I say is correct. And the third thing is, no matter what, you bring a rabbit with 4 legs, he still finds it that my rabbit is only with 3 legs. So he never accepts for anything. So, in these 3 forms, which one do you think Mahabharata is all about? It is all about the first part, that is Samvada. It is a conversation between the Supreme Lord and a conflicted soul. Okay. So how can we relate this to our profession or as a professional in our clinics, like be it you're practicing speech pathology or you're practicing audiology, how are you going to relate this Samvada to your daily practice? It is more of communication, okay? And even more than that, if you again go back to the basics of Mahabharata and observe, there is a conflicted soul. Whose is a conflicted soul here? It is? The battleground is all prepared, the warriors are all ready, the plans are all ready, okay? But who is the one who has to be Pioneering this, Mr. Arjuna, the so-called best warrior this world has ever seen. But he has a conflict within his, like, I don't want to kill my own people. He knows what has to be done. As someone said, like, he is fighting for his kingdom, his righteousness, okay? His, everything that he has lost over a period of time, what was supposed to be his. But now, he is fighting with his own relatives, that what needs to be achieved has to be achieved. When the time comes, he is feeling like, okay, now I can't do it anymore. So now there should be a person who can guide him, who can show him what is right, what is wrong, okay, and how to achieve your goal, to stay focused on how to achieve the ultimate goal. So don't you think that is the right way to do it? So, with this being said, I would call in my own language, so there are two people here, one is a counselee and the other one is the counselor. So which leads us to the today's topic, that is all about strategic and rational counseling in audiology practice. Because I am talking here in particular about audiology practice, but it is same with the speech practice as well. So why did I tell you the story? Because there was a strategic and rational counseling that was done to Mr. Arjuna by the Lord himself by showing his Virat Rupa, which we call as Vishwarupa, and he has to show all the paths, all the ways, and counsel him, convince him to reach his ultimate goal. How are we going to adapt this to today's session? Let us see. So before going to that, what is counseling? It is a process in which a professional tries to, first you need to understand your client. So I keep on saying, because I'm taking up a role of trainer now, wherein I train the budding audiologists, whomever we hire, and there are many other profiles whom we train about, but I keep on saying to all my end users, that is the audiologists, branch heads who directly have an interaction with a client, that all the questions that you answer in an exam is only to get your degree certificate. But when a question comes from your client, that's the time when you will have to answer it, and you cannot give the same answer. See, like you get in the mid-unit, you get a question, you write an answer, you get marks. The same question comes in your final annual paper, you write the same answer, you get the same marks. But here it is not. This is the battleground. So this is all your clients are Arjunas, and you will have to take up the role of Krishna here. So when a question comes from a client, you cannot give the same answer to two different clients, because you need to understand your client here. Okay? So many questions come in. The same question, will it be sufficient if I wear one hearing aid? This is what I used to hear as a practitioner on a daily basis, at least when I see 5 to 6 clients for hearing aid fittings. Is it not enough to wear one hearing aid? Is it, my loss is so worse that I need to wear hearing aids at all? I'm at the end of my life. Why would I might pass away in another 5-6 years. Why would I need a hearing aid? So much of conflict. Okay. So you need to understand the client, their problem. So say in a simpler way, you can say like the problem is hearing loss. No, that is not the actual problem. The problem here is the attitude of the client towards that hearing loss. The understanding of the client, the impact of the client or the hearing loss on the client's lifestyle, how it is going to affect. So what is he looking for? So that is what you need to understand, their problem, their behaviors, their thoughts, and finally you need to discuss with them what it is all about. So what are the solutions that are available? How are you going to analyze the situation? How are you going to give them a solution which they can accept it readily? And believe me, they will not accept it readily. You need to counsel, recounsel, make them, give them a confidence that it is going to work. And in the end, when you give a fitting or when you do a fitting, they should not be expecting, yes, there should be a miracle happening. Right immediately after wearing a hearing aid, there should not be any more problems in my life. All the problems that I have seen like these days should be gone like this. And does it happen? Speak up, guys. Does it happen? No. So how are you going to convince your clients? So there should be a path for it. There should be a rationale for it. Like when you promise something or when you guide your client, we never promise anything. We only guide and we only prepare them. That's why we say like we have to prepare, which takes us to the next stage, like why is it to be done? It is to be done to motivate the client and make them accept the unchangeable. So they should first understand that no matter what, any kind of SN loss is irreversible. No matter what, you give the best of the best technology available out there, you give them the best discount possible, but still they ask, is one hearing aid is not enough? Or can I take some medicine and avoid it for some more time? Or can I go and meet a doctor to get a surgery done? So, no matter the best of the best solutions that you provide, they still have doubts. So, which takes us to the next point of the counseling, that is, it is a never-ending process. It has to be done again and again and again and again, which we will see in the later slides how it is to be done. Right. And why do we need to do it? To prepare the client to prioritize and set their goals confidently. Okay. Prerequisites, which means like how do we counsel? Now there are some 20 to 30 students here. Okay. Now in a year or so, all of you go start your own practices or you start to join some firms. Okay. And approximately there should be in your vicinity some another 4-5 people doing the same practice. You all will be provided with the same products, right? Almost all will have the same top 4-5 manufacturers brands that you have. So what do you think that will hook a client to you rather than your competitor? So what is that one virtue that you need to have to hook your clients only to you and have them for you for a long time? So you need to have certain characteristics. You need to develop certain virtues. Other than your technical skills, other than your knowledge of the product, no matter how good a programmer of a hearing aid you are, no matter how good you are at the diagnostic part, no matter how good you are at differential diagnosis, there are certain virtues which you need to develop. That is, the first one is your listening skills. As soon as you see a client in your clinical therapy sessions or in your sessions, you might be observing during the diagnostics. So you will be given a set of questionnaire, right? You all practice the same, I guess, in colleges, right? That's how we trained ourselves. We'll be having a strict questionnaire wherein we will, so what is your name, what is your age? If we don't ask them, we see in the bills, we write it down. Then, what is your problem? Okay. You have come for, okay, PT and impedance was recommended, okay, you'll do that. Finally, you'll write the average, then you'll write the diagnosis. You say, okay, Tata, goodbye. Now go and meet your physician back. So if that is done, you are getting a very limited amount of information. So what you need to do here as a difference is, you need to understand your client. You need to give a chance to your client to speak up. Okay? So you should, before that, you should be able to give your own credentials, like who you are, what is your capacity, what is your caliber, and greet the client, make them comfortable, just allow them to settle down and explore, go in-depth analysis of the problem, which not only will give you the information about the problem that you are looking, but it also gives you the information about the knowledge that the client has, the way how he is handling his daily living with this problem, how confident is he psychologically, all these things, or what is his future plans, how ready is he to accept these solutions that you are going to give. So you get to know all these things only by communicating with your client. So, and such, you have to have the virtue of listening. So when this conversation is going devoid of the path, you can bring in always, you should monitor your conversation with your client, you bring them back into the conversation, stay focused and keep listening to your clients, because whatever they speak up to you, you can pick up those bricks and build your wall very strongly while doing a counseling. So all the problems that they pose is a problem for them, but for you it is a chance to hook up to them more firmly. The more and more problems that they pose, the better and better you have the chance to hook up to them, to give them more and more information, more solutions, right? So the prerequisites are listening skills. And can someone tell the difference, what is the difference between sympathy and empathy? How is sympathy and empathy different?
Empathy is giving help also.
Okay.
It's like making them feel you.
Yes. Sympathy, what is it? You feel sad for someone, right? When someone is going through a pain or to a trouble, you feel sad. And does this help a client or someone who is going through that phase by feeling sad? So that's why you need to have empathy. What is empathy? Empathy is when your client says, sir, I'm not able to hear these days properly. I'm not able to understand, I'm not able to focus. If you say, Ayyo Pao, this is sympathy. Empathy is, yeah sir, I can understand. There are millions of people out there who has the same problem, but good that you have come to us. At least you are trying to find out a solution. Let me help you out. So giving a helping hand, encouraging them, trying to understand at the problem with their views and visions is empathy. Okay, trying to understand them, understand their problem and giving them a helping hand is called empathy. It is more of a constructive conversation that we make with a client. Next, you need to have what is called as congruence. What is congruence? It is like, again, if you go to your bachelor's or master's, you see the brightest of the brightest student in a class, right? Who knows technically everything. He is very good at every subject, but he'll always come as a third or fourth when the exam results come. Why? Can someone tell why? Because he has the technical expertise, he knows the information, but he don't know how to deliver it. So the issues with the deliverance, you might be good at technical knowledge, you might be good at the technology of a hearing aid, you know the solution. When a client asks this, I have to do this, but the framework of your entire process, the structure that you have made, or the limited exposure that you have with the client will not help you to speak up much better with a client. So that's the reason why we go to the first place, that we need to give a helping hand to the client, and you need to hear from the client first so that you can frame your time. So, okay, this client has come with these many questions, so this is the approximate time that I might need. So even before you spell out the answers to those questions, you need to have the entire scenario, how long it is going to happen. So what if a client comes in between? So what should I speak? What language should I speak? What tone should I speak? Okay, what are the words that I need to use to convince or make this client comfortable and understand? So this is what is called as congruence. It is simple. It is a framework that you need to, and this framework is different from client to client. It is different from person to person, problem to problem, everything. But overall, it is within the boundaries of your strengths. Okay. So overall picture is same, but the way how you paint on that canvas is completely different. Next, you need to observe the time factors as well. You cannot stretch Within my observation that I have seen over the past 15 years, a typical session with your client should not be lasting more than 30 to 40 minutes or maximum of 45 minutes. That's the time I give for each client. So believe me, lesser than that, you are sending your client with very limited information. I'm talking about a first-time user, not an experienced hearing aid user. A first-time user, if you are trying to give him a hearing aid, the session, if in my comfortable zone, I feel like 45 minutes to a maximum of 50-55 minutes, not more than that. So you should schedule your appointments and you should see to that you are not void of this particular session. Within that time frame, there should not be no distractions, because that will give you a impression to your client that, okay, this guy might be good, but he is not able to concentrate well on my. If you say like, okay, you please wait in the middle of a conversation, I have a testing done, it only takes 5 minutes, I'll do a PT and come. So the impact that you are having on this particular client is, he feels like, okay, this might be good, but he is not the right guy for me. So he is not giving proper attention to me. So this is what is going to happen. So you need to frame your time also. Like, yes, coming back to this, 45 minutes, why I said, like anything less than that, you will send your client with inadequate information. Anything more than that, hour, 1.5 hour, 2 hours. There are sessions which I have done even for a single hearing aid counseling for more than 2.5 hours, half day. Believe me, it is never going to close. It is never going to end. In the end, the client doesn't have a satisfaction. You should know when to start and when to stop also a session. If it is going too lengthy, you are indirectly giving the control over the session or the conversation to the client. So he will drag you to all the ways, whichever ways he wants, and finally there will be no solution for that session. So you should also keep yourself bound within the time frame. If possible, please do tell it to your client before that, I am going to have this session, your slot is for 45 minutes. So anything here and there you can give for another 5-10 minutes, not more than that. If you keep on entertaining this, you will lose your process. So you will never try to adjust, you will never try to get yourself into the process which you have framed for yourself. Right? Yes. And this is what I call as PPP model. In the prerequisite, what are the virtues that you need to have? So this is what I call as PPP model, which is called as pre-consultation, peri-consultation and post-consultation. Okay? So the main core crux of interaction happens for the 30 minutes or so when the client sees you for the first time. So within that first impression or the first chance that you meet a client, you have to make an impact. That is, the client should get a confidence that yes, this is the right guy whom I am checking for. He can give me a solution. He can show me the path. So how do you inculcate that confidence in a client within the 30 minutes time frame that you get to have an interaction? So I would say, like, you take at least 15 to 20 minutes, initial 15 to 20 minutes for the client to come up with all his problems. You should never stop a client confident. You should never stop your client while he is speaking. At least give them a free hand of 10 to 15 minutes. Let them speak, build your blocks, have all the puzzle blocks in your kitty bag, then start to frame your solution for him accordingly. So for that, you need to have this PPP model, what I call it as pre-consultation. What is happening in a pre-consultation? There are 3 A's: ambience, abundance and activeness. What is ambience? Ambience is nothing but the way how your workplace looks, how the hygienic or the abundance of the information, that is, you are prepping your client, you are preparing your client to go through a process that is happening, what is going to happen in the next 30 minutes. For me, the counseling starts even before I see a client. right? For example, let us think like my front office executive or a GRE is very new to the profession and she doesn't know how to welcome a client. Okay, she doesn't know how to greet a client, how to give her information about the process of a client. How is it going to happen? How is the client comes with a negative mentality? Okay, this guy is not hiring quality people. Okay, he doesn't want to hear what I am trying to say. He will not open up because of the bad experience that he had as soon as he enters my clinic. Okay, so you need to have a proper ambience and abundance of information. You need to prepare your client even before he start to have a consultation with you. Have adequate brochures, have adequate information. So all this are the preparatory stages of your consultation or the counseling. Next, you need to have activeness. Activeness of what? I call activeness of the process. So there should be a standard structured process. You need to greet the client, you need to welcome them, okay, tell them the process, how it is going to happen. All the success people, if you observe any of the biggest organizations in the medical industry, at least Apollo hospitals or Care hospitals or any other hospitals, all the hospitals who are more successful, if you observe, they are all process oriented. So they have a process in place. No matter what, whatever you are, whoever you are, you have to go through the standard structured process. So if you have that, that is your client comes, your GRE or your front office receptionist goes, greet them, okay, welcomes them, explains them, give them some pleasantries, give the abundance of information and start off with saying that, okay, you will have your consultation.
Excuse me, sir. Sorry to interrupt. 5 minutes left.
Who's?
5 minutes left.
Okay, that's
Thank
it. And the 2 more slides, okay. So we'll start off with these things. So then you have the peri-consultation. How? This is the most important topic, okay, or the part of the counseling wherein you will start to, you will have the most important part of this is affirmation. What is affirmation? It is giving them the positive attitude or approaching them in a positive way, only talking about the positive. When they say like, oh, I have these many problems, what do you say? You say, it's okay sir, don't worry about it, there are solutions available. You all the time talk only, even of the negatives, you talk only in the positive ways. Okay, and you should be agile and you should be acceptable. Acceptance of what? You are trying to give some solutions and the client says, no, I already have gone to a client, they said the same thing, so this is not going to work, I tried hearing it. So you should be ready to accept the negativity from a client. You don't expect a client to immediately say, yes, okay sir, I'll do whatever you say. So there will be some sort of negativity and you need to understand and you should be accepting that and move on with it. And post consultation, once the sale is done or when you try to fit a hearing aid to your client, then you should be accessible and aidable. What is accessibility? That you should be present for them. You should not feel, okay, the sale is done, I've got my money, now let the client go off, I'll never see him again. No, that is not the way how we are dealing with our clients. So after taking a hearing aid, they'll come back for follow-up, they'll come back, they'll call you asking questions. You need to answer them, address them with patience and reaffirm again and again. Believe me, it is going to be okay, it is going to be okay, take your time. You need to counsel them again and again and again with variety of questions that they pose, and you also should have variety of answers. And finally, so the summary of this is, these are the stages that you need to follow up. Preparatory stage, that is you know to know the client and client gets to know you, okay, then you understand the client and finally show the possible solutions, and always this is the important point, that is demonstrate the benefits. So there are two things, the short-term benefits and long-term benefits. So you need to explain rather than before the client asks you the question, you should say them, yes, it is going to happen, and you should explain them what are the short-term benefits that they are going to expect and the long-term benefits that they are going to get over a period of time. If you can clear those of all the doubts of a client, then he'll be more confident, he'll be more enthusiastic in participating, he'll come back again and again with more and more questions, which would be fun in a session. And finally, evaluate, conclude, and follow up. Even though your client follows you up or not, you should always follow up your client. How is the hearing aid working? How are you? Is it working fine? Is there anything else that I need to do it? Okay. So, that being said, this is a basic preparatory presentation that I have made for you all. So, if you have any doubts, I'm open to take your questions for the next 2 to 3 minutes. Do I have time? Yes.
No, we are out of time.
Okay, if you have any questions, the time constraints. So I'll be available at my store outside, so you can come and discuss if you have any doubts in relation to
So
this.
I just
Sir,
wanted to
there's
make
one
one
question.
comment.
Sir.
I'm sorry. It was good presentation. This is my understanding. I think I have only problem with 2 words.
Sir.
Okay, I may be wrong. During counseling or during seeing a patient, we should use the word patient rather than client, because it's a healthcare sector. In future, when we are asking for insurance, I think we should use that term. That is one.
I'll take it
Yes,
into
sir.
That's
consideration,
one.
sir.
Another thing you said,
Correct.
when a patient tells about his problems, you use the word I can understand. I think no one understands anyone's problem. I think the better word what they have been talking about is that I know these are the problems. Because understanding is, say for example, only you can understand your problems. I
Yes,
cannot,
sir.
unless you are not in his shoes. So we don't use the word I can understand your problem. That's
Okay.
what we say in terms of aphasia when I work it. I will never know what is his problem. I know the problems are there, but I cannot understand what is going on in his mind. I know the problems. Yeah, those are the better words. That's what we said. Okay.
Sure, sir.
But otherwise, it was nice. Thank you.
I'll take your words. So, any more? Okay. Thank you all for your time.
Thank you, Sai, for your detailed counseling procedure about hearing aid trial. I hope I would be very happy that if this topic is included in our from the bachelor's syllabus, then it would be very helpful, because the batch which are coming out of the college, they have very limited knowledge about the counseling procedure, and they have no practical exposure. So that is actually a very difficult situation, because we as a colleague or a employee in an organization, we know how people take it very difficult way to learn these things. So if we have a clear knowledge about the counseling procedure, I think the subject knowledge, of course, everybody are thorough about it, but only the problem is counseling. So if this counseling syllabus is included, that will be really helpful. Thank you.
Thank you so much, Sai Koti Garu. A very good presentation, and hope all understood and will carry these beautiful tips in counseling patients based on the rationale and the strategies which you can use in the clinical setups. Thank you. Thank you for the opportunity, ma'am. Thanks.
Thank you so much, chairs, for giving your tips as well. And I would like to ask you to give a token of appreciation to Mr. Saikot. Thank you. I would request the chairpersons to appreciate the token of appreciation. Accept. Thank you, sir. Thank you, Sai Koti, sir. And chairpersons, Bhuvaneshwari ma'am and Ramesh sir. So please stay on stage. We would like to ask you to please accept our token of appreciation for being your chair for this session. Thank you, ma'am, for chairing the session. Thank you, Ramesh sir, for chairing the session. Thank you. And now I would like to call upon Mr. Vijay Shankar sir and Mrs. Renuka ma'am to chair the next session. And I would also like to call up Dr. Arivuday Nambi sir to present his excellent presentation. And I would like to introduce him as an Associate Professor, Department of Audiology and Speech Language Pathology, Manipal Academy of Higher Education, Karnataka. He has an academic profile of PhD in contribution of auditory, spectral, temporal and cognitive processing abilities to speech recognition in noise among old adults in Manipal Academy of Higher Education. He has done his Masters of Science in Audiology in Aish and Bachelor's in Speech and Hearing in also in Aish. He is an Associate Professor, Assistant Professor, selection grade and senior scale. He is also a lecturer of audiology and speech language pathology in MRF, and he has also done his lectures in Mangalore. Thank you, sir. We welcome you to give your presentation. Thank you. You can use this, or you want to call him out?
Thank you, ma'am. First of all, I would like to thank the organizers for giving me this opportunity. The topic that I am going to present is things taken for granted in selection, fitting and verification of hearing aid. How much time do I have? So 45 minutes. 50 minutes.
10 minutes.
Okay, so I have 30 minutes to complete my talk. So some of the slides I'll skip through. Theme of this particular conference is bridging the gap between the research and clinical practice, that is recent advances in rehabilitation research and its application to clinical practice. So I've given 30 minutes of time. Okay, I'm sure this is madam giving me instruction. Actually I may be talking only for 30 minutes. It may feel like 3.5 hours for you. Trust me, it's only 30 minutes. Now okay, this is a basic step in any hearing aid fitting and verification process. Generally when patient walks in, as sir pointed out that I should use the term patient only. Any patient walks into the clinic, you do the basic audiological assessment. Okay, so that includes your pure-tone audiometry, speech audiometry, and that alone is not sufficient for hearing aid selection. Okay, you do perform special tests. They can be either questionnaire based or objective tests. I'm not going into those details. Based on this pre-fitting assessment, you select the hearing aid and then fit it. After fitting, we verify using any behavioral or objective measures, and then you fit the hearing aid and send the client patient home. Okay, and then after a month you call him and check whether the hearing aid is really benefiting him in a real world situation. That we call it as validation. Okay, so what are the things that is taken for granted in routine clinical practices? I'm sure all the audiologists do check for threshold of audibility, that is audiogram. But what we miss out is loudness discomfort level. But this is a very important parameter in selecting as well as fitting the hearing aid. Okay, I'll just another few slides I'll be talking about how the LDL or uncomfortable level helps in selecting and fitting the hearing aid. Okay. And okay, this is one of the favorite template of meme creators. So I thought I will also use the same template for my presentation. So this is the audiologist always giving importance to the gain of the hearing aid, but often we miss out the MPO. Okay, the MPO also an important parameter in optimizing speech intelligibility as well as loudness discomfort. Okay. Now, see, all of you know what is MPO. That's the maximum power output of the hearing aid. That is, irrespective of the input intensity you give and irrespective of the gain you give, there is some saturation limit beyond which the hearing aid will not be able to give any output. For example, if the MPO of the hearing aid is 100 dB, means whatever the gain you give, the maximum output that the hearing aid will give only will be 100 dB. So you may think that, okay, so the hearing aid is amplifying. After the amplification, the output is being limited by either a peak clipper or a hard peak clipping, output stage compression. So it should be affecting the comfort, not the speech intelligibility. But I'll just give you a small example. Let's assume that this is a speech signal. So you have a waveform of a speech signal. Let's assume that the intensity of this portion is 75 dB, and here it is 30 dB, and here it is 70 dB. And you are applying a non-linear amplification, that is 33 dB for this portion, 50 dB for this portion, and 35 dB for this portion. That means the signal will be amplified to the level of 108, 80, and 105. So this is after amplification. But what if your hearing aid, saturation limit, that output is only up to 100 dB. Okay. So now what will happen? These peaks will be limited to 100 dB instead of 108. Same way, this peak also will be limited to 100 dB instead of 105. So essentially what happened? The peak to valley depth reduces, which is very important for the speech intelligibility. So if you select a hearing aid, you may select the hearing aid with appropriate gain, but if the MPO is too low, then that also may affect the speech intelligibility, not just a comfort. Okay. So now, do I get to know before selecting the hearing aid itself? Okay. One basic rule that I would suggest is, now for example, morning I was just looking through this GN fitting software. So this is the audiogram. The same audiogram I plotted on both the sides. If you see, the software recommends moderate power receiver for this audiogram. Okay. But if you see, the fitting range is just 10 to 15 dB below the, just 10 to 15 dB above the hearing threshold. So in these cases, it's very highly likely that your MPO is also less. Okay. So you have to be very careful in selecting this hearing aid. So when you fit this hearing aid, for a softer speech, you may say, I can understand well, but if the person stands next to him and speak, or if he speaks very louder, you will say the speech is not very clear. So in that case, you should go for a receiver which can give a better headroom. Okay. So, sorry. The same example. Here also if you see, the headroom is very less. Okay. You can see the MPO here. 100, 115, 110. But if I increase the power of the receiver, the MPO is elevated to 115, 131 and 115. Okay. But both the hearing aid may give a same gain. Look at the gain. Gain given is same, but the output is enhanced when you select the higher power receiver. So you always, just don't look into the gain. You also look into the MPO. And MPO is not just with the receiver. You also have a techniques to optimize MPO. That is your peak clipping or compression. I will tell you how to manipulate those parameters. Okay. Now, as I said, it is not just the inherent property of the hearing aid. We have a controller to control this MPO. Now, how do we decide at what level to set this MPO? And it's often decided by loudness discomfort level, or also called as uncomfortable level. Okay. It is always advised that you estimate an uncomfortable level or LDL for a frequency specific stimulus. In most of the clinics, we do it for speech, but it is ideal that you use a frequency specific stimulus because the MPO is frequency specific. Okay. Each frequency you have a maximum power output. So to decide what should be the MPO at different frequency, you should estimate LDL in different frequencies as well. Okay. But most of the time, many clinicians, would agree that many times you don't enter this LDL data. Okay. Especially, the students who are performing or just finished and who are coming up, they don't enter the LDL data. Okay. In that case, then how does the hearing aid or the fitting software optimizes the MPO? Okay. So often what happens, this fitting software does the job. if you don't enter the LDL, it predicts the LDL. Okay, the software itself will predict the uncomfortable level. Okay, for example, if prescriptive formula DSL version 5 selected, the prescriptive formula itself will predict LDL, but NAL and NAL2 do not predict LDL, but the company specific formula may predict it. Okay, so how these manufacturer specific algorithm or the prescriptive formula predict LDL is based on the normative data. Okay, so now I am just presenting one normative data. If you see, let's take 1 degree of hearing loss, 60 dB of hearing loss. The lowest UCL is 70 dB and the highest can be 130. For a given degree of hearing loss, the uncomfortable level can vary by so much, 70 to 130. But what fitting software takes is, this is the average data. So moment you enter the hearing threshold as 60, your software will assume that his UCL is 100. But this client may have this or may this. So sometimes what MPO you sit may overshoot his UCL, sometimes it will very much undershoot the MCL. Okay, but both has a negative implication in your fitting. How is that? We'll see. Okay, so this all of us are aware of this. Whenever the MPO is set above the individual's LDL, it will exceed his loudness discomfort. So obviously he will turn down. So this is well known negative consequence of setting a MPO that is too high. So individual either stop using the hearing aid or you will reduce the overall volume. So the gain of the hearing aid also comes down. Not just the MPO, the gain also will come down. Now what if the MPO is set too low? Okay, now this person is saying the signal is highly uncomfortable. So I will set the MPO at very low level, much below the LDL. Now here the blue color one represents the speech signal and the yellow one is a steady state noise. You can see the steady state noise filling up the dips of the speech signal, thereby reducing the modulation depth. The peak to valley depth reduces. Okay, so here itself the speech undergone degradation, thereby the speech intelligibility will come down. When the MPO is set much lower, once again the peak amplitude are going to come down, the modulation depth is going to further reduce. So this is going to affect the speech intelligibility. If the MPO is set too low, speech intelligibility is going to be affected. If it is too high, the comfort is going to be affected. So you always have to estimate the loudness discomfort level and set your MPO just below the loudness discomfort level. Now, sorry. Okay, so as I quote you are saying, he has hardly 30 to 40 minutes of window per client. So in this limited time, how can I administer so many tests? And if I have to get the frequency specific LDL for each frequency, it is going to consume lot of time. But one advantage with UCL is, if you remember the MAP-MAF curve that represents the threshold. Threshold highly varies across the frequency, but the UCL will remain same. So if you observe equal loudness contour, as the intensity increases, the curve becomes flat. So the MCL generally remain flat irrespective of the frequencies. So if you can estimate UCL for two frequencies, that itself is enough. For other frequency you can interpolate or extrapolate. So often it is advised to estimate at 503 kHz or 750 at 3 kHz. Remaining frequency can be interpolated or extrapolated. Okay, so that software itself does it. Okay, so that is about measuring the uncomfortable level and feeding the data of uncomfortable level for proper fitting of the hearing aid. Now moving on to the threshold of audibility. Okay, so many a times what happens is, while programming the hearing aid, we simply enter only the air conduction threshold, but the prescription of gain do not depend only on the air conduction threshold. It mainly depends on the bone conduction threshold. Okay, if we see the NAL prescriptive formulas always calculate the gain based on the sensory neural loss. Okay, and the sensory neural loss portion is obtained by a bone conduction threshold, and then a 75% of the correction is applied based on the airborne gap. Okay, so in this case you have to enter both BC threshold as well as AC threshold in the fitting software, then only the calculation of the gain can be appropriate. Okay, but one more thing that we have to be careful here is, sometimes there can be a false airborne gap that is present, either due to improper calibration value or due to tactile sensation. Okay, So the software will not know whether it is due to tactile sensation or it is true sensory neural sensitivity. So you have to take care of it. Okay. So next, next thing I was observing is when selected this, I went to audiogram module. If you see, by default, it showed insert earphone. When I clicked on the Phonak target fitting software, the selected transducer by default was insert earphone. I don't know whether it happened only in my system or it is always like that. Now, this is very important. Now here what does it mean is, you are entering the hearing threshold and you are telling the software that I measured this hearing threshold using this insert earphone. Now why this is important? Okay. When the prescriptive formula calculates the gain, it doesn't calculate the gain based on these values. These values are transformed into some other value. Okay. They are called as real ear SPLs. Now these are all just audiogram HLs. These audiogram HLs are converted into real ear SPL. For that there are some correction factors used. Okay. And those correction factors are, okay, this. If you say headphone, whatever the HL you are entered in the headphone, that will be transformed into real ear SPL by adding a REDD value, that is real ear to dial difference. If we say it is insert earphone threshold, it will add RECD. If we say it is a free field threshold, it will add RUG data. So depending on the transducer you specify, the fitting software will apply appropriate correction factor. Okay. So this REDD can be either measured on that particular individual or it can be a normative data. But it is here is always something is better than nothing. Instead of simply blindly giving some value, you select the appropriate parameter so that the transformed value to some extent matches with the values of that particular individual. Okay, so this is what I was telling. When you measure in the audiogram, when you say 70 dB HL, it means 77 dB SPL. That 77 dB SPL corresponds to a coupler, okay, but not the real ear value, because your audiometer is calibrated in a 6cc coupler. So dial reading always correspond to the coupler value, not the real ear value. So to transform it to the real ear value, we add these correction factors. Okay. So that is one thing that we often overlook. Next is prescription of gain. Okay. So we all know that the gain is, we don't, in a trial and error method, we don't randomly provide gain. We always follow some rules, and those rules are called as prescriptive gain. Okay. These prescriptive gains can be broadly categorized into validated prescriptive procedure and proprietary prescriptive procedure. Any fitting software you go, by default it will go to the validated prescriptive method. That is, the company itself develop their own proprietary method, but based on some rules from the validated ones. Okay. So generally we don't recommend the proprietary procedures because they are not widely tested on many patients, and the transformation of what I said, the REDD, RECD, REUG, they may not be properly normed. So it is better to always go for a validated fitting method, because the normative has been applied on a large population, so that the transformations value is also quite accurate. So I am just showing here the Phonak adaptive digital is one proprietary method specific to Phonak hearing aid. Here you can say audiogram plus is one proprietary method specific to GN resound hearing aid. Okay. So any fitting software by default it always goes to their proprietary method. Better up to the audiologist to change it to the validated method. Okay. So there are various studies which have shown that proprietary methods, the gain provided by the proprietary methods largely deviates from the validated methods, and the validated method provide minimum difference between the preferred gain of the patient. Okay. Now when it comes to validated method, today we have two common method. One is DSL version 5, the desired sensation level version 5, and then NAL NL2. So initially what happened when NAL NL1 was there, we always thought that NAL NL1 should be used for adult, DSL for kids. Okay. But NAL NL2 has been optimized for both children as well as adult. Same way DSL version 5 also has been optimized for adults and children. So the bigger question is, which one should we choose? The NAL NL2 and DSL version 5 both use different principle. The amount of gain given also slightly different. okay? But when you compare it with the gain preferred by the patient, they are not largely different, do not make any clinically significant difference, at least in the frequency range of 500 to 4 kilohertz. But in the fitting methods, the frequency beyond these 4 kilohertz also important, that we will see in the next presentation by Vijay sir. Okay, so the question is, so clinically, which one should I use, DSL version 5 or NAL NL2? Ma'am, I related to the theme triple R now. So if you ask who is the better performer, RAM or beam, I'm sure we will not be able to tell. The same thing, DSL version 5 or NAL NL2. There are no proper clinical evidence available to show that one is better than other. Okay, so it's up to the clinicians to check out both, and whichever give the best response you can choose. And there is also a need for studies to compare these prescriptive methods on Indian population. Okay, so that is about selection of fitting formula. Now next is, so gain, MPO, all those things are the basic parameter that we look into any hearing aid. But sometimes, or not sometimes, many a times we have to properly fine tune the special features. Now how do I select the special features, or what special features he requires? Okay, so that is done by generally questionnaires. But if you have a very busy clinical setup where there are a lot of patients, you will not be able to submit the entire questionnaire. So in that case, you can ask these 6 questions. Okay, so these 6 questions will tell you about the attitude of the patient, whether is he really motivated to take the hearing aid, did he understand, or did he accept that he has hearing loss. Sometimes what happens, patient has hearing loss, while talking to me he'll realize you ask some question, he gives different response. Okay, but patient thinks that he is giving a correct response, but actually it is not correct. So he doesn't understand that, or he doesn't accept that he has a hearing problem. Those are the patients which are difficult to convince. Okay, so you may have to adopt a different counseling strategies as pointed out by the previous speaker to make him understand the problem. Okay, and then it also tells you what are the situations he has a problem and what are the features to select. Okay, so we'll just take one example of speech perception and noise. Okay, how do we, if a person says I have problem in speech perception and noise, so I want a hearing aid which can help me out in understanding the speech better in the noise. Okay, so generally there are 3 different methods available in the hearing aids. That is wireless data transmission, where the speaker has a mic and the information transmitted wirelessly through either 2.4 gigahertz or NFMI or FM. Other one is directional microphone, also called as beamformers. So when 2 microphones in one hearing aid, we call it as monaural beamformer or directional microphone. But this directional microphone information can be combined across 2 hearing aids with the help of wireless data transmission, that we call it as binaural beamformer. Okay, and then we have a noise reduction algorithms. So if you see hierarchically also, the wireless data transmission tops, that gives the maximum signal to noise ratio enhancement, followed by the beamformer. Within beamformer also, general consensus that binaural beamformer provides better SNR enhancement than the monaural beamformer, but it is not. I will show you in the next slide. Other one is noise reduction algorithms. Okay, so generally the directional microphone makes use of 2 microphones to improve the SNR. When the signal comes from the front, the 2 microphones information generally gets summed up, the signal level increases, and generally the noise is assumed to come from back side, so the output gets subtracted, the back level sound coming from back gets suppressed. Okay, so as I said, there is a general thought that binaural beamformer, that is combining the information between 2 hearing aids, can give a greater advantage. So but we conducted a study, it was published recently, and we did not find any improvement. That is, having a binaural beamforming, that is the wireless transmission between the 2 hearing aids is no better than each ear having the individual beamformer technology. Okay, so next moving on to the noise reduction. This wireless transmission and directional microphone do improve signal to noise ratio, but these noise reduction algorithms, in most hearing aids what you see as a noise reduction algorithms actually do not improve the signal to noise ratio. Okay, it is highly depends on the context. Okay, first one is Wiener filter based noise reduction. It does improve the signal to noise ratio. Since I don't have time, I will not be able to show the audio demo. If at the end of the presentation, if there's a time, I'll show the audio demo. Okay. So this Wiener filter based noise reduction can improve signal to noise ratio only if the noise is non-speech in nature and relatively steady over a time. The speech has got highly amplitude fluctuations, whereas the traffic noise or any other machinery noise, they are steady over a time. So what this Wiener filter noise reduction algorithm do is, wherever the speech pause is detected, it will continuously analyze for the voice activity. Wherever the pause is detected, and it estimates the level of the noise in those pauses. Whatever the level we estimate in the pauses is taken as a noise, and that is removed from the entire signal. That is called as Wiener filter based noise reduction. This to improve signal to noise ratio, but only for non-speech noises, not for cocktail party situation or speech babble. Now this is another strategy. Okay, this is a amplitude modulation based noise reduction algorithm which do not improve signal to noise ratio. Okay, so this is also called as multi-channel adaptive noise reduction algorithm, where the input signal is divided into series of narrow band, like your what happens in a multi-channel hearing aid, and each channel these amplitude modulations are estimated. Wherever the amplitude modulations are present, it is assumed as speech. If the amplitude modulations are not present, it is assumed as either only noise or the speech is dominated by the noise. Okay, so if both speech and noise is assumed to be present, the overall gain in that particular band reduced. Okay, so when you reduce the gain, you are not only reducing the gain for noise, you are also reducing the gain for speech. So since the level of the speech as well as level of the noise comes down, the relative SNR remains same. So this method do not improve signal to noise ratio in the hearing aid. Okay, so often especially the freshers who start off with the clinical practice, if the patient says, okay, I have the listening need is I want to understand speech better in the noise situation, okay, I'll select the hearing aid which got a good noise reduction algorithm. But the noise reduction algorithm do not address the problem completely. Okay, it is highly situation specific and depends on what kind of algorithm which is there in the hearing aid. So the knowledge of that is very much essential for the audiologist to address the patient concern. Okay, so I am not going to all those things selection. Now other promise often we do is while counseling, as Koti has already pointed out, if a person has problem in 2 years, should I go for 1 hearing aid or I should go for 2 hearing aid? So we always say we go for binaural hearing aid fitting. We do say 2 years is always better, but always we say the first thing that we highlight is the localization. If you fit hearing aid to 2 years, you will be able to localize the sound better, but actually that is not true. Okay, so we did a detailed analysis of published literature. We did find that fitting 2 hearing aid do not improve the localization ability. Instead, it can decrease the localization ability compared to the unaided performance. Okay, so what you should highlight is the balanced hearing. Okay, so you will be hearing through 2 years, so the loudness will be better and the speech perception noise better, but don't give promises about localization performance. Okay, so that is all about selection and fitting. Now moving on to the verification. Okay, so in many of the presentation I do highlight the importance of real ear verification. So most clinics only the aided audiogram is used for verifying the fitting, whether the hearing aid has been fitted optimally or not. Okay, but the real ear measurement has greater advantage because aided audiogram has been measured only on limited frequencies, whereas the real ear measurement can be performed on continuous frequency scale. The next is supra-threshold audibility. Now what do I mean by supra-threshold audibility is, okay, I'll show it in the next slide. Now we have a hearing threshold. In this case, his threshold is 80 dB. Okay, so whenever you amplify the sound, the amplified sound should have the level above 80 dB and 90 dB. Then only it will be audible to him. So this is called as magnitude of audibility or amount of audibility. That information we don't get in aided audiogram. I'll just take an example of this. When you give 60 dB of input, the output of the hearing aid is how much? 90 dB. Okay, a 60 dB input, that is normal conversational level, gives an output of 90 dB. That 90 dB is just 10 dB above the hearing threshold. It is only 10 dB above the hearing threshold. This is called as magnitude of audibility. Okay. So when you look at the aided threshold, aided response is 40. But if you look at the audibility, it is too less, just 10 dB above the hearing threshold. So this information is not available to you if you use only aided audiogram. If you take, if you use a 4, like this is 2:1 compression ratio. Last one more slide. So if it was, with a steeper compression, where the compression ratio is 4:1, the output is 85 dB. Okay. So when you alter the compression ratio, the amount of audibility gets changed, but your aided threshold will remain same. Okay. Your aided threshold will remain at 40 only, but the amount of audibility is just 5 dB. Okay. So this information you won't get it in the aided audiogram. Okay. Whereas if you do a linear measurement, you can see the output, because by placing a probe microphone, you are measuring the hearing aid output in the ear canal. So you will know how much is the amplified output is higher than the hearing threshold. This is hearing threshold and this is the amplified output. So you will get to know it is almost 15 to 20 dB above the hearing threshold. So I have provided the adequate audibility. Okay. Sometimes you connect the patient comes to you and say that I can't hear with the hearing aid. When I switch on, hearing aid gets switched on, I can see the light blinking, but I don't hear it. So when you connect it to the programming software, now see, it got connected. The hearing aid got connected and it is perfectly matching the target. Okay. But when you measure the real ear response, only got to know the output is too low. Okay. Here is the hearing threshold. Output is supposed to be like this, but the output is here. The output of the hearing aid has come down, which you not got to know if I use only the aided audiogram or simply go by the fitting formula. Okay. So there are many other applications of real ear measurement. Anyway, because I have only limited time, I will not be able to point out on all those things. So I do advise that even real ear measurement is one of the overlooked procedure. The clinician should consider using a real ear measurement in fitting and verification. Okay. So this is my university, and this is our college, Kasura Medical College, and these are my colleagues who works with my most research projects. I did present few papers. All those papers are done along with these people only. Okay. So this is our research laboratory. We do actively work on the signal processing related to hearing aids and cochlear implant. Okay. Not directly to the clinic, mostly in the experimental level, and we also look for these algorithms in the clinical level itself. And this is our lab, and anyone interested in knowing about the lab can go through this paper, and the email address of all of us is available in this paper. Thank you.
Thank you, sir. Thank you for so directly pointing out what has been taken granted in hearing aid selection and fitting. I hope there's a good take-home notes for all of us. Thank you. Thank you, sir. Yeah.
Hope I did not go very fast.
No, sir. It was very clear, intelligible for all of us. Hope we had more for you. Any doubts from the audience?
We almost involved into the topic.
Yes.
To check
Yeah.
the time also. So we are very happy.
Any questions? Yeah.
Don't touch down. Maybe you can ask a little louder. I think it's audible.
Sir, I have a small doubt, like high.
Hello.
Yeah. Hi, sir. How binaural it will help in healthy hearing? Can you explain in a brief way?
Means in a normal hearing individual. No?
Yeah, sir. In a like healthy hearing, how binaural summation it will be help and how it will be useful?
Okay. So generally the binaural hearing helps in speech perception in many ways. One is better speech perception noise, especially when the speech comes from one direction and noise comes from other direction. The binaural cues helps to segregate the target speech from the noise So that is one cue. Other one is the loudness. We know the speech intelligibility highly depends on the audibility. Though we may be having a normal hearing, but if the person stands very far and speaks soft, the amount of information above the hearing threshold is too less. If person has hearing normal in one side and affected on the other side, he is perceiving only through one ear. So the amount of audibility is less. But whereas if he has hearing on both the sides, so the loudness gets summed up, so the audibility increases. That will directly impact the speech perception. So basically the loudness summation improves the audibility. Thank you. There is one more.
Hi sir. Thank you sir. First of all, the presentation was very nice.
Thank you.
But I have very quick doubt. You have mentioned somewhere, you have done research also that binaural hearing aid fitting, it's not give benefit in the localizations.
Yeah.
So I'm just curious to know, because so far what we came to know, and all the companies, even the latest technology, MARI receiver in the resound, they are more claiming that this will be help to localizations when they are going to binaural fitting. So I'm just trying to understand where is actually the fact. I mean, either your research or the company is claiming, what so far we came to know, from our college time.
Okay. Actually, the paper what I showed here, it is not our research. We did a review of published literature. We are doing a research. I did not show the result. Even we did find the same thing. Aided is poorer than the unaided.
Right.
And we are developing an algorithm to improvise this binaural hearing. Okay. Now, so when I talk about localization, it's a three-dimensional phenomenon. So to say whether signal is coming from up or down
or right, left,
that we call it
front
as
and back.
Vertical perception or elevation perception. So the signal comes from top, it will directly enter the ear canal, hit the different portions of pinna and re-enter. So the summation of direct and redirected sound will create a spectral peaks and dips. Okay, the perception of spectral peaks and dips is important for perception of the elevation. Okay, even microphone in the canal cannot replace this. Why? I'll tell you. The microphone can pick up the spectral peaks and dips, but it has to go through the same cochlea which is already impaired. The cochlear frequency resolution is so poor, they will not be able to resolve these peaks and dips, so still the elevation perception is going to be poorer. Next comes is front back localization, for which the pinna shadow effect is important. Yes. Okay, like 15 dB of attenuation is there beyond 4 kHz. So the microphone location is above the pinna, so pinna shadow effect is not captured. Once again the front back localization affected. Through split directionality, to some extent we can compensate for it. The next comes is horizontal plane localization, to say whether it is coming from this 30 degree or 40 degree or 50 degree, for which the ITD and ILD cues are very important. The ILD cues are distorted by the compression, level dependent amplification, that will minimize the ILDs. That can be compensated by to some extent with the help of coordinated compression. Okay, but the restoring the ILD do not restore the binaural hearing. That's what most research shows, because what is important is the interoral time difference or interoral phase difference, which is distorted by the hearing aid signal processing. There are a lot of filters used in the hearing aid. The phase distortions introduced by the filters do not preserve this IPD, which is affecting the localization ability. Okay, and just quickly I want to highlight one more thing here. Generally say you say the ear impaired individual will not be able to localize, but sometimes when I knock the door, they look at the door. So this localization can be either knowledge based or the cue based, because I know where the door exactly. So if I understand what door sounds like, so I look into it. The next is error. We say when we go out, if there is a bus horn, we just look, turn and look, but we don't look at the precise location. We will be looking here and there. That we call it as error. That error of localization. Even a normal hearing individual localize with some error, but with the hearing loss getting into, the error gets widened. Okay, so we may be locating the signal with the larger larger area. The error may be large here. Okay, so that error will remain same even if it is the hearing aid. The angle of error can be much higher than unaided condition, or it can remain same. So what was the study we reviewed? Most of them pointed towards saying that the binaural fitting do not improve the localization error when compared to the unaided conditions. So here in our research, we are not looking to improve localization. We are seeing how the binaural cues can help in speech perception and noise.
So the localization
Yeah, at least our priority is not localization. Restoring the spatial cues to improve the speech perception and noise.
So how about the cross hearing, sir? Because so far the cross hearing process, basically it is depend on the localization. So
No,
there is
cross-
also binaural fitting. It's a kind of one is like live hearing aid, another is a mic to improve the localization from the poor ear side. So somehow can be, help to these patients, or it is just for the
No, that's what I said. Localization, if you say up, down, front,
Yeah,
back
I
is
understand.
monaural phenomenon.
Clear.
With 1 ear we will be able to. But
Right.
when it comes to horizontal, it is always the auditory system, central
Right.
nervous system, combine the information from 2 ear to derive the location. So even in cross hearing, the information goes to only 1 ear. So the binaural cues are not there. So your brain has to come up with some alternate mechanism to localize. Like when I say bus horn means it can be back side, door means can this side. Like knowledge based localization can be taught to those individuals.
So I just wanted to add one thing. I think cross only helps in reception of the sound from that side, not for localization. That is one thing. The second thing, this thing, most of these companies, my clinical experience I'm telling, most of these companies claim that this localization helps if you use 2 hearing aids based on their logarithmic data and mathematical studies. But in practice, when we do, this stands good. Most of our patients are not able to localize with 2 hearing aids. So that is the difference between theory and practice. Yes.
So would monaural, Nammi sir, here sir.
Yeah.
Sir here, chair. Sir, so the review clearly establishes unaided is better than aided in localization.
Yeah, localization error.
How about monaural fitting? Would that be better than binaural fittings?
No, actually this review, we did not look into that. We had so many other parameters to control for it. We just taken only binaural fittings.
So one more question, sir. Yes, really a verification gives very good value for fitting, but for small clinics to look at the cost benefit also, on a scale of 1 to 10, how much would be the difference of using real ear measurements and fitting and without real ear measurements?
Okay.
Just to view in point of cost benefit.
Yes. So, we have not done a cost benefit analysis because I work in institutional setup. So our institution provides the equipment. If one equipment goes, we'll get another equipment. So right now we have 3 real ear measurement equipment. But in our clinical practice, what I understand is doing a real ear measurement improves the patient satisfaction, which in turn improves the, I don't know whether it is right to use the term loyalty. Okay, the patient repeatedly comes to you. I have seen many patients who got the hearing aid fitting done somewhere else, but they are not very happy with the fitting when they come to us. For the follow-up fitting, they do come to us. Also, with the first instance, when you do a real ear measurement, the number of follow-ups can be minimized if it is properly verified using the real ear measurement, because we are sure what you have fitted and what the patient is receiving. But if you go by behavioral, what happens? We are working on speculation about the audibility. See, if the patient comes back to us, we'll know whether this is not proper, so I have to do something else.
So number of fine-tuning sessions
Yeah.
have reduced drastically with real ear measurement.
So this is what my senior used to say. When you go to a doctor, he gives you a medicine and tells you to come after 2 weeks. This is just to check whether you are alive or not after 2 weeks. Whether medicine. So it is same thing. No.
Thank you, sir.
This is his view, not my view.
Sir, you spoke about speech perception in noise, and if we give binaural, in quiet environments, will there be any benefit, or is it the same?
Because that's a binaural benefit. Generally, what happens? We highlight 3 things: improved loudness, and better speech perception noise, and localization. What I am saying is, we shall not promise about the localization. We shall talk only about the loudness summation and better speech perception noise.
In quiet, will
No, quiet also, because the audibility is improved.
will it help in localization in quiet?
No.
Even for
No.
even in okay.
Yeah.
Even in quiet.
In and quiet, yes.
Okay. So we should not promise
Yeah, that's right.
client that you will have better localization.
Yeah.
Sir.
That's right. The successful hearing aid fitting always depends on what expectation we create. Sometimes patient will come with unrealistic expectation. We have to counsel them to develop a realistic expectation. How do we meet his expectation? That is a successful hearing aid fitting.
What is the best feature in hearing aids, sir, according to you? What is the best feature in hearing aid?
To my knowledge, so far now, the wireless technology that they have introduced.
That's the best one.
Best one. It has helped to solve so many problems in our patients.
It's
Maybe
better
that,
than noise reduction.
Yeah, definitely.
Thank you, sir. I think no much. Thank you, sir. Thanks.
Thank you.
Thank you so much, sir. Sir, I would like you to come on stage to accept our token of appreciation, and I would like to ask the chairpersons to give a small token of appreciation to Mr. Nambi, sir.
My presentation is recent advances in prescriptive methods of hearing aid fitting, and in that bandwidth.
Thank you, sir. And I would also request our chairpersons for this session to stay back for the next paper as well. Okay. And yeah, you can take the memento, please. Thank you, sir, for excellent summary and giving us the points further on the presentation. Thank you, ma'am, for chairing the session. And please stay back for the next presentation. Next presenter, Saha, sir, but unfortunately he couldn't be there for the event. So, but then he took all the efforts to send us the video of his presentation. I hope you can see the presentation, and in case any doubts, he will be there online, and also Nambi sir will help. Vijay Narne sir, Vijay Narne sir will be there online to answer the questions, and also Nambi sir will help you to answer the question, and the chairpersons will continue for the video.
Yes. Thank you.
Good afternoon, everyone. My presentation is recent advances in prescriptive methods of hearing aid fitting, and in that largely talking about extended bandwidth in hearing aids. So what is extended bandwidth in hearing aids is nothing but providing amplification above 4 kilohertz. Most conventional hearing aids do not provide amplification above 4 to 5 kilohertz. So there is a recent advancement in how to fit hearing aids with providing higher frequency amplification. So this presentation is my presentation largely divided into 3 sections. What is prescriptive formulas? That I think most of us know. So I'll briefly touch upon that, and then we move on to see what is the importance of high frequency information. When I say high frequency information, I basically mean information from 6 kilohertz and above. And importance of high frequency hearing information in hearing impaired individuals, and why not, if the high frequency information is important, why not it's been implemented, and how it is now possible to implement, and what is the advantages of this implementation with reference to speech perception, spatial localization, and preference, quality preference of the hearing aid. And finally, I'll just touch upon what is nonlinear frequency compression hearing aids and how is that different from the extended bandwidth hearing aids. And finally, a small conclusive statements. So introduction, most of us know what is prescriptive formulas, and there are different types of prescriptive formulas. Largely used were NAL-NL, DSL, desired sensation level, CAM, it's from the Cambridge formula, and proprietary formulas. Every company has their own formula prescribed, so we can use that. And largely NAL-NL, DSL, and CAM are derived based on loudness normalization and loudness equalization techniques, whereas proprietary formulas are largely derived from the machine learning techniques, where they take large number of subjects who are fitted with the hearing aids and they see which hearing impaired individual uses what type of gain more commonly. So based on that, they derive the formula using a machine learning technique. So this is the difference between the currently available prescriptive formulas. Earlier, most of these prescriptive formulas are not able to provide amplification above 5000 Hz. Now, recent advancement has come up to give amplification above 5000 Hz. Now, why is high frequencies important? Let us see whether that really has any advantage of using high frequency information. Now, it has been well documented in many studies that high frequency information does improve speech perception, but now this has to be looked at in a different perspective. Now, in English, sir, sh, z are more commonly occurring phonemes, whereas in Indian languages their occurrence is less. Now, in that perspective, definitely speech perception will improve if you increase high frequency information. So that can be seen in the plot here. As they improve the information above 2 kilohertz, the speech perception starts increasing as we start giving till 16,000 hertz. So because of that, it is clear that for English, definitely yes, it does provide information, but how far does this help us in Indian context? That need to be explored, and I don't think that there are many studies in this aspect. Second, the high frequency information also helps in localization. So how does it help in localization? Let us see. It is said that high frequency information above 8 kilohertz does provide a front back localization. So there are many investigators have explored this. So this is one sample that I am presenting here. They filter out the information from the low pass cutoff frequency 16,000, 14,000 hertz, 13,000, 12,000, 10,000, 8,000, 9,000 and so on till 1,000 hertz. They filter the signal and they assess the front back localization. You can see that till 9,000 we can clearly say which is front and which is back signal, whereas when the signal the frequency content in the signal reduces less than 9, then there is a confusion. So we only either say front or back. So because of that, it is clear that information above 8,000 hertz definitely helps us in localization. Once we know where the signal is coming from, which direction coming from, then paying attention to that is easy, and which will definitely help us in speech perception. Now, does it help in language development? With reference to English, fricative sounds are more commonly occurring, and also they play a significant role in linguistically they play a significant role. Basically, all the fricatives are morphological markers in English. Because it is a morphological marker in English, so language development depends on the morphological marker. So language development is impaired if high frequency sounds are not perceived in English. So hence it is important to provide high frequency amplification. Probably that is the reason they came up with nonlinear frequency compression and extended bandwidth technologies were largely came up probably for this purpose. And let us try look at how far does that get affected in Indian languages. In Indian languages, fricatives are less commonly occurring, and fricatives does not serve multiple linguistic functions in Indian languages. So the maximum peak of sir is at around 7 to 10 kilohertz range, and hence fricatives are less common and they don't serve any linguistic purpose. So they are not basically morphological markers in Indian languages. So we need to know how far, if we don't perceive the sa, it affects the language development. It's not question about high frequencies are not important for understanding speech. It's a question about does it influence language development. I don't think that we have any information on this yet. Further, how does it help speech perception in hearing impaired individuals. So till now we have seen what is normal, and now we are seeing in hearing impaired individuals, probably with hearing aids or without hearing aids. Early on, speech perception adults reported, remember this, why it was not implemented early, because in 1990s, most of the studies have clearly documented that any information above 4 kilohertz is not important for speech perception. So a significant ones are Ching from National Acoustic Laboratories, Hong and Turner from US. So they documented that if you increase the information above 4 kilohertz, for those individuals with greater than 60 dB of loss, it will not help the speech perception, rather it degrades the speech perception. Hence it is clear that it is not important to provide any amplification above 4 to 5 kilohertz. And those individuals with a significant hearing loss maybe are associated with the dead regions. It's a recent information, so from this we can derive that probably those individuals with a significant hearing loss have a dead region, and hence providing any amplification within the dead region is of less use, rather it degrades the speech perception. So speech perception and noise is improved only in individuals where the degree of hearing loss at high frequencies is less than 60 dB. And further, more improvement is observed if the speaker and the noise are separated. Then providing high frequency information does improve speech perception. And high frequency information from 4 to 10 kilohertz improves ability in hearing impaired participant to understand target speech in the spatially separated masker. So magnitude of head shadow increases with progressively with increasing frequency. So listener can attend selectively to the ear where the signal to noise ratio is better. Hence high frequency sounds are used for localization, especially for resolving the front back confusion. So here is just an example for you to see how does the speech perception gets affected if you move the head. So let us say low frequency information in the speech largely does not get changed, whereas from 1000 to 2000 hertz, from about 3000 hertz,
there's a small
you can see that there is a significant spectral change with the head movement.
There's a small notice.
So
he's having a blue car.
So this is the listener and he is the speaker. So if this speaker turns the head, you can see that there is a significant change in the high frequency.
0027.
So because of this, there is that helps us in localization, and then we can separate the noise from the speaker, and that can be used in the speech.
If anybody is here, please.
Second, in a more complex situation where it's something like a cocktail party, so if there are these two are noises, and if you turn the head towards different directions, how does the speech gets altered is shown, and with no high frequency information, there is at least improvement of 2 dB in the signal to noise ratio. In the speech reception threshold in noise, there is a 2 dB improvement, so which indeed says that high frequency information does help us in speech perception. No. Then why not it is being implemented early? It is because Ching and Hong, they have done a systematic study where they have removed the information above 1 kilohertz, above 2 kilohertz, above 3 kilohertz, and so on till 8 kilohertz. And they observed that any information providing any amplification above 4000 has not been shown any significant improvement with reference to speech intelligibility index, and also there are some subjects where it is getting degraded. That is maybe because those individuals have a significant loss and there is a dead region, so they are not able to show any improvement. So that is the reason they did not go for using the amplification. So it is said those days that it is not required. One. Second reason why it is not implemented is fitting formula derives the gain based on the speech information and the degree of hearing loss. Now the speech information has low amplitude at high frequencies, and amount of hearing loss is higher at high frequencies. Because speech information is low and speech intensity is low and hearing loss is high, so you have to give more gain to get into that level. Because of that, they are not able to provide more gain. If you give more gain, then the problem is there is an acoustic feedback which influences the speech perception. Then the feedback comes up and they have to adjust the acoustic feedback. So then we have to reduce high frequency information. So that's this is not so they did not work those days. So now are they able to implement now, and what was the technological advancement which allowed us to implement these now? We can see that there's a significant technological advancement, and hearing aid amplification was not given 4 to 5 because of the technical limitations that I have already talked about. So there is an improvement in the signal processing power, that is they are able to design a multi-core processor which allows a microphone to record and sample at a rate much higher than 44,000 hertz rate. So they are able to sample now. So then we can definitely provide high frequency information. So that is technological improvement from the microphone direction. And also RIC or RIT hearing aids, or ITE hearing aids, that is receiver in the canal or receiver in the ear hearing aids, can provide much higher amplification at high frequencies without acoustic feedback. So these two advancements have helped us to implement extended bandwidth hearing aids. Okay, so let us say they have implemented the extended bandwidth in hearing aids. So is it able to achieve the gain, target gain? Then only we can say that no, it is useful. Otherwise, it's not useful. So let's see which type of receiver is able to provide good amplification and is able to reach the target. So there is a recent study by Michael Stone. So they have compared with the receiver in the canal, receiver in the ear, ITE hearing aids, receiver in the canal hearing aids, and deeply inserted analog devices. So you can see that the receiver in the canal and ITE hearing aids are able to achieve the target much better compared to DIAA hearing aids. So the black line here, this black line here is actually the target, and this red one is for the RIC hearing aid. So it's almost able to achieve the gain which is prescribed by the target. Of course, it is only till 7 to 8 kilohertz, and above that there is a decline in the gain. And second better is ITE hearing aids are also able to achieve the gain as recommended by the target, but DAA hearing aids, there is a significant difference from the target to that at high frequencies. So DAA hearing aid, that is deeply inserting analog hearing aids, are not very helpful in providing high frequency information. Okay, so these hearing aids are able to provide high frequency information and they are able to reach the target. However, is that information is audible to the individual? So that we will see. So there is a study in 2012 by Brian C.J. Moore and Alexander Seck. So what they did was they have derived the gain, and with that gain they amplified the speech, and the amplified spectrum of the speech is being plotted on the curve. So this line is actually amplified speech. Now, and they also converted the threshold, hearing impaired individual thresholds, into dBHL, dBSPL, and those thresholds are plotted, and this is MAP curve. And now we can clearly see that till almost 8 kilohertz, 8 to 10 kilohertz, the speech information is much higher in amplitude compared to the hearing threshold, which indicates that it definitely provides amplification, and this amplification is makes speech audible to the individual till 9 kilohertz. So that helps speech perception. So that information is available. Now, does it help in language development? Yes, there is a series of studies done in Boystown University, and they have extensively documented that there is significant improvement in the learning of language. It is much faster if they use extended bandwidth hearing aids. Further, they also said that new world learning is much faster if they implement extended bandwidth hearing aids. that is with reference to Western countries, but as I told you before, we don't have information on the Indian context, so we really don't know that part of it. Coming to speech perception, studies have assessed speech perception and noise on people with a hearing loss with wideband, restricted band, that is amplification less than 4000. And subjects with a mild hearing loss showed some benefit with widening the bandwidth. However, individuals with a severe loss at high frequencies do not show any benefit. As documented, as explained before, likely that they have a dead region and it degrades the speech perception if you provide amplification at high frequencies. Now, comparing the nonlinear frequency compression, I think all of you know what is nonlinear frequency compression. If you don't know, in a brief words, the information from 4 kilohertz to 8 kilohertz being compressed and fed into the region less than 4 kilohertz. So that any speech information above 4 kilohertz is audible to the individual with a regular conventional hearing aid. So that's how the nonlinear frequency compression was implemented. Now, extended bandwidth without any compression, they actually give the speech signal. So hence, nonlinear frequency compression will have some amount of distortion, but extended bandwidth hearing aids will not have any distortion. Because it has less distortion, so maybe that speech information is more useful. So let us see whether it is useful or not. Do the individual prefer extended bandwidth hearing aids or nonlinear frequency compression hearing aids? So it was noted that both children and adults showed preference for extended bandwidth hearing aids if the individual has lesser hearing loss at high frequencies. That hearing loss is less than 60 dB. If there is a greater degree of hearing loss, those individuals preferred NFC, that is nonlinear frequency compression, over the extended bandwidth and restricted bandwidth hearing aids. Now let us look at how does nonlinear frequency compression and extended bandwidth hearing aids help in music perception. For music perception, participants with less degree of hearing loss choose extended bandwidth, and participants with a greater degree of hearing loss did not show any preference. That means even if you give nonlinear frequency compression or extended bandwidth hearing aids, they have no preference, so they don't prefer any of it. And similarly, Moore and Tan in 2003 compared with the various bandwidths. Largely the restricted bandwidth is 0.3 to 3.4 and extended bandwidth is 100 Hz to 10 kilohertz. So they noted that if the individual has a less degree of hearing loss, they prefer extended bandwidth, but if they have a significant loss, then they do not show any preference. So finally, to conclude, so basically to summarize, yes, we can implement extended bandwidth hearing aids. They are indeed helpful in speech perception, language development, and also in music perception. And the extended bandwidths has an edge over nonlinear frequency compression. However, all this information is from the Western languages. There are major differences from Western languages to Indian languages, largely with reference to language development and speech perception. So we really don't know how far extended bandwidth hearing aids help us with reference to speech perception in noisy conditions or language development. So that need to be explored. So basically, to summarize, yes, extended bandwidth hearing aids are very helpful if the subject has less degree of hearing loss at higher frequencies. If the individual has a significant high degree of hearing loss at high frequencies, extended bandwidth hearing aids are not helpful. And even with reference to the music perception also, it is the same issue. So with that, my presentation comes to an end, and we have references here. Thank you.
Thank you, sir. And any questions from the audience? Nambi sir will take it up.
Any questions from the audience? Dr. Nambi sir is here. Sir Vijay Narine sir's presentation. or chairpersons can summarize so that Sonal ma'am can take over.
No questions.
Yeah.
It
Thank
was
you,
clearly
sir.
explained.
You can, yeah, you can summarize and end up.
To summarize quickly, so Vijay Nane sir was talking about extended bandwidth technology. So most of the hearing aids, we all know that have gained till 4 kilohertz. Extended bandwidth technology is nothing but where we have gain beyond 4 kilohertz. Some hearing aids till 6 kilohertz and some till 8 kilohertz. So that technology is available today with the help of two things. One was RIC with the RITE technology, because there is a less chance of acoustic feedback. They can give more gain in high frequencies beyond 4 kilohertz. And the another reason was now we have fast processing microphone technology. So because of these two technologies, we can give extended bandwidth amplification also. Then it was clearly established in English studies that is it useful, extended bandwidth giving amplification beyond 4 kilohertz, is it useful? Yes, it's very well written that it is helpful in speech and language development also, it's helpful in localization also, and it's also helpful in speech and noise. But it still need to be derived for Indian languages, how much helpful it is. And with the technology, there are so many studies has presented, whether it's helpful or not. Again, English studies, yes, they say that there is a great benefit. Especially when the loss is below 60 dB, extended bandwidth is helping better than frequency compression. Now we have frequency compression and extended bandwidth for high frequencies. So we can conclude that for loss below 60 decibels, better to choose extended bandwidth, and for loss above 60 decibels, better to go for frequency compression technology. I think, am I right, sir? Anything missed? Okay. Thank you, sir.
Thank you so much, sir, for chairing the session and summarizing for Chandan Saha, sir. And we'll be going for the next
yes,
speaker. Thank you. Now I would request Mrs. Sonal Chitnis, Miss Sonal Chitnis, to come for the next, come as the next speaker. And I would like to call Miss Ramya Mahati to chair the session, and Mr. Funny sir to chair the session.
Lunch break. I hope people do not get to sleep.
I know. Trust you. So I'll just introduce you and then you can take it. So it is my immense pleasure to introduce Ms. Sonal Chitnis. She has specializations in the area of bilingualism, aphasiology, cognitive neurorehabilitation, advocacy in brain health, humanitarian, neural correlates, and allocate cortex cognitive linguistic intra-op and extra-op mapping, education and training in LMIC neurorehabilitation. She has years of experience, that is 16 years plus experience in focused work in neurological rehabilitation of speech language, cognition and swallowing disorders, especially epilepsy, pathological aging, stroke, MCI, PPA and related dementia, TBA and MCA. Thank you so much, ma'am, to listen to you about neurological concepts in speech language pathology. And over to you. And
thank you so much, Lakshmi. APSLPA team, it's a pleasure to be here, and I always look forward to meet APSLPA. It's close to my heart because my initial days I was here. My studies are from Hyderabad SRC, Alia Varjang, and it has built up my initial career, my in fact a love for cognition and communication from Nizam Institute of Medical Sciences and Alia Varjang collaboration. And I tried to carry this ahead when I relocated to my hometown, Pune. So with my sincere gratitude to the audience who stayed back and are still awake, interacting, I would like to go ahead with my talk on recent research development in assessment and neurorehabilitation. My job was very made easy by Goswami sir's yesterday's lecture. He made you understand what is cognition, what is communication, what is PPA, what is dementia. So some things might be slightly overlapping. I tried cutting down the heavy research, evidence-based articles when I understood the crowd is more of students, youngsters, and I don't want to make you feel, oh, that neuro is so difficult. Always I heard from the students that, ma'am, palle nahi padta hai ye. And that's how they don't like to go into neurology, neurosurgery and departments and try to build a post that, see, I am capable of working, helping your team, and please let me work, than going to just pediatrics and otolaryngology workup. So I'm here to advocate for research studies, clinical competence developing. And why do we do research? Is to develop ourselves as a better student, better clinician, better faculty. And in India there is a huge scope, and essentially we require to have good tools which can tap the cognition, which can tap the communication, language. And we need to have a protocols for our Indian patients. All the patients we see are not similar with the background, literate or illiterate they come from, with the education. All the patients we see are not same with the lifestyle they live, lifestyle they have been living, and pre-morbidly in terms of their psychosocial, their socio-economic status, and the culture. So when we say understanding, remembering, reasoning, or making ourselves what we are, it is cognition. You need to be aware about yourself. You need to be aware of that, okay, you are from this background. You need to be aware of that, oh, you are Telugu, you are Kannadiga, you are Marathi. The food we enjoy, it starts from the culture, that we need to make our protocols that what do we assess. I'm sure I can't have a place of pizza substituted by bhakri for Italian or American patient I'm assessing. Whereas same thing, I cannot substitute the same task or tool, picture or a sentence from the American, Australian protocols they have developed. Yes, so we require to have recent advances in cognitive, communicative world. And when there is a neurological disorder, it may get regressed, damaged, and some things might be preserved. So we need to really work on it. So hence this is what is important for us. My disclaimer is I don't receive any financial help from the Isha, IFNR, IN, WRA, WHO recently have got into, but it's my advocacy work, and APSLP has helped me, sponsored me a trip here. However, this talk would try to help you understand what as a SLP one should assess and can address in terms of major cognitive communicative disorders. So I will try to focus on cognitive communicative disorders, majorly with my cognitive impairment to moderate to severe in terms of dementia. RSD and TBI I would just touch upon, and what is brain health and research. So for the students from UG and PG here, I'll try to put forward how you could conduct research in cognitive communicative health. So you all know that our brain is enigmatic. Consciousness, creativity, your artistic nature, your aggressive versus very kind or versatile nature, it's all because of the brain you have, the genetics you have inherited from your parents, and the environment which modifies that, which makes you the hyperactive or hypoactive or very talkative versus very, very preserved, reserved, versus intellectual, quick grasping versus 3-4 times or you mug up and then you get some acquaintance of that hold on the subject. You're learning your language, the way you speak, the way you learn different languages, the way you learn different skills, acquire. It's your brain, mind, and that's how you should be knowing in cognitive communicative health. So you have two hemispheres in the brain. I'm sure they are still active and they are still functioning. So can you all please tap once, wink once, twice, whistle. Oh, I think people can't whistle here. Okay, so I hope you're awake. So left hemispheric functions and right hemisphere functions both are important and they are integral in terms of making you learn the language. Telugu, Marathi, Hindi, English, Gujarati, Kannadiga, whatever languages we read, write at home, learn, and the official language, English, if you are growing up and going to the vernacular medium, also if official language is introduced. If you are learning in English medium, a second language, also you are introduced to the language first. So it's important that you understand when someone gets a stroke. It could be a pediatric stroke. I see young children like 8-9 years old as younger at 4 years old child with pediatric stroke. So that is cognitive communication disorder which can lead to, if it is a right hemisphere damage and the child has difficulty in visualizing, not able to speak. However, we don't call it aphasia in a younger population when they have not acquired language lateralization, language dominance. And as you grow, your motoric functions, your language functions, your music, your memory tries to get shifted as per the branching, as per the making the folders in the brain. I hope you are all understanding what I'm talking. So one, it's important that one needs to know that it's not just language is limited to left hemisphere. Your pragmatics, your artistic, your music related language requires you, and your rhythmical, your phonological abilities do have some backup in the right hemisphere. But majority of right-handers, we have a language in left hemisphere. So then there is a focal left hemisphere damage. We tend to see difficulty in understanding, difficulty in naming, difficulty in reading, difficulty in writing. So aphasia is a multimodality disorder of language in terms of understanding, speaking, reading, writing, gestures, calculations. I would add that we do say music also is a very important modality. Instrumental music doesn't require words, but the music in terms of lyrical requires a language, meaning, and it has a bihemisphere activity. So that also could be earlier ahead saying that aphasia and amusia goes hand in hand when someone does not perceive the words with the lyrics, without lyrics, or gets a tune wrong. And there is much more to do with you SLPs to understand. All Broca's aphasias respond to your melodic intonation therapy? No. And why not? Because the prosodic perception, feedback, and the musical abilities in terms of post-stroke or post-head injury or post-brain tumor could be different in that person with aphasia who is non-fluent. So cognitive communicative health is a global burden when there is a high incidence of degenerative disorders, demyelinative disorders, neoplasm, brain tumors. Stroke post-pandemic has really been having a surge. So one should understand the cognition is tapped across 3 important domains. There is a verbal domain, the social domain, there is a visuospatial domain. With that, we have motoric cognition and sensory cognition, and as well as emotional cognition to understand. SLP plays an important role in understanding, exploring, assessment, and rehabilitation of cognition. So you play an important role, integral role in a neurorehabilitation team at acute care when a patient is neurologically stable, neurosurgically stable. And it could be traumatic brain injury, it could be a right hemisphere damage disorder post a head injury, or a right frontotemporal tumor, or a right hemisphere hippocampal atrophy, or a typical right neuroinfectious space occupying lesion. The disorders can be same or different, symptomatologically can be different as per the etiology. Pathology matters there. So you need to understand neurology, a basic bedside assessment, CNS and PNS, and we shouldn't be rigid, frogs in the well. No, we need to go, learn, interact, advocate about your role, and also role of SLP needs to first thing that educate, equip yourself. So our field is very vast, our scope of practices are vast. One should really learn to update, learn and do unlearn if you have been rigid and if you have not learned it correctly. So there's an amalgamation of art and science in cognitive communication disorder, CCD. Okay, so there is an inseparability between the language, learning, cognition and communication. Yesterday, Goswami sir has really made a beautiful presentation about the BCC test, what they have developed in Aish, and then the projects and phenomenal work, what they have done. So I think I will skip on what do you require to test in verbal, spatial and social cognition. So PPA is a primary progressive aphasia, is importantly a cognitive communicative disorder because it's a clinical dementia syndrome. It starts with a language onset, so person doesn't get correct words. It might be non-fluent in nature as predominant incidence, but you might get to see a semantic dementia, a semantic variant where person has trouble getting correct words, trouble understanding what is spoken, and the person can be happy-go-lucky, speaking fluently, having a jargon imitating. However, this aphasia, primary progressive aphasias are much better in initial stages than your any vascular stroke-based aphasias. And how non-fluent is a non-fluent PNFA could be different as per the test you are giving him or her. So connected speech is very important. Next is your other degenerative disorders like Parkinson's disease. Yes, you need to understand language in Parkinson's also, which many SLPs fail when they just apply FDA or the swallowing abilities in PD. But language, subcortical degeneration in the left hemisphere and right hemisphere might give a rise. The degenerative language and communication abilities needs to be really tapped. Whereas corticobasal degeneration, then Alzheimer's disease remain your challenging CCD domain. Right hemisphere damage is very important cognitive communication disorder where you have to tap pragmatics and communication in terms of sense of humor, presence of understanding joke, satire, understanding the exclamatory markers, questions, orders, understanding the theory of mind, how the person loses when he or she cannot see the half visual picture and correctly, coherently put together a picture. So you need to know cognitive linguistic disorders and cognitive communicative disorder. Now what is the major change? Now aphasia is considered as a cognitive linguistic disorder, and PPA, TBI, RHD we say predominantly it's CCD. So there is a thin line to understand, and one may see there is a importantly poor cognition and good cognition, a kind of overlapping trajectories with person with RHD, unable to get semantic recognition, and many times the higher linguistic abilities are not tapped on our Western aphasia battery or our traditional screening of language and communication. And communication, test of communication, many of us do not agree that we have it, we learned it and then we need to, we are testing it. So how many of you know FCP? Can someone just tell me? Anybody has administered the FCP if you are in third year bachelor's or in first year MSc? No? But I'm sure in your curriculum you are supposed to know functional communication profile or CADL, communication for everyday activities, for communication tool. So we don't ask the person and we don't even take history adequately for communicative competence and performance in first language, second language, third language. So it is important that we understand cognitive communicative world where you are going beyond language in terms of attention, awareness, executive functions. Your competence for your second language you have learned long back. Your third language you have learned long back, and then you're still able to read, write, communicate adequately. So the students here, I would like mic to be given to the students. So can you tell me what is CCABI, if you have heard this word? Anybody here? If not, I would like you to please download a simple quick checklist for cognitive communicative abilities for acquired brain injury. It is not limited to traumatic brain injury only. It can be any acquired neurological insult, and that checklist is for nursing, medical, other professionals, so that they can refer you a patient. If it can be used as outcome measure for pre and post at bedside also. Okay, so aphasia, apraxia can comorbidly exist with RHD when it could be crossed aphasia, a right-handed person developing right hemisphere damage disorder with neurological disorder and unable to speak or understand, name, read, language modalities are impaired. That is called crossed aphasia. That could be because of the asymmetrical language representation in the right hemisphere in a person who is right-handed. So one should understand the RHD CCD. However, there are many persons with dementias, they do not have a language onset, but could be a memory impairment as an onset, and later can have language and communication impairment. So they could be difficult in getting correct words from storage, memory access versus lexical access. So it is important that you know research on cognitive communicative disorders, specifically directing on lexical semantics, where you retrieve the words in spoken modality. So all of you will quickly tell me as many names of companies as possible you know of. Time starts now. In 30 seconds. Loudly, names of companies. As many, I said, generate names of companies in 30 seconds as fast as possible. All hypoglycemic brains? Okay, name as many animals as possible in 30 seconds.
Dog, lion, tiger, cat. Dog, lion, tiger, cat. Leopard, elephant.
This
Monkey.
is word retrieval. This is called verbal fluency task. It's a generative naming task. This requires your hippocampus of left hemisphere to be intact and a parahippocampus to get you the storage that whatever you have learned from a childhood, the names of animals. And then your brain is trying to conflict between, oh, not animals or birds. Is it domestic or wild animals? What did she ask? How quickly I should recall? Should I say in Telugu? Then Hindu chappala, Telugu chappala. So that's how your bilingual brains try to conflict and still try to answer in the code you are asked in. So executive function. So verbal fluency is an executive function, and executive function is very important for your language acquisition, for a bilingualism, multilingualism, in your everyday learning, everyday communicative abilities. Post-stroke, post-head injury, post-degenerative mechanism, it gets regressed and thus can affect your communicative abilities. So one should know the incidence and prevalence of cognitive communication disorder in terms of understanding what is the research and what do I know. Do I have some Indian research available? So one should know that it's more of senior citizens, above 50, 60 years, aging brains, highly susceptible for cognitive communicative neurological morbidity. Whereas we do see patients with middle age or early older persons with lifestyle, with the genetics, with the inflammatory markers at risk of developing stroke or dementias. And there are sporadic familial cases of dementias, stroke, and other autoimmune encephalitis, which have the onset as difficult in getting correct words, not able to remember, not able to quickly perform the activities of daily living versus activities of independence. So one should know the incidence and prevalence. We do get to see neoplasm, brain tumors in young patients, and high-grade tumors are the important cause for dementia in younger population with the rapidly progressive dementias. So brain tumors are important. When there is a high-grade tumor, they tend to have a chemotherapy, first resection of the brain tumor, and eventually the same person who was having only mild anomia or difficulty in getting correct names or recall generally deteriorates across all the motoric, sensory, verbal, social and cognitive domains in general, what is important for everyday life. So pathology matters, that one should know what is the symptom. Aphasia is a symptom, dysarthria is a symptom. However, as a SLP we see this disorder and we need to understand the symptom of aphasia. It changes as the patient has a good vascularization post-stroke if it is given adequate TPA, a life-saving agent, and in case the patient has a hemorrhagic stroke, they do decompress, and mechanical thrombectomy could be also life-saving in the person. And the same person with global aphasia, right hemiplegia, severe dense apraxia could come to Broca or anomia or no subtle deficits day 2 or even the same day after 10 to 11 hours in case you are in a good quality stroke unit. So there are reversible cognitive impairment, language, visual special skills, attention, orientation, awareness, recall, personality and your behavior are important cognitive domains to assess. And you cannot take out language from cognition, you cannot take out cognition from language, it's the interdependent. So does thought exist without language? Think. Can language exist without a thought? So thought process, reasoning, thinking, your ability to retrieve is interlinked, and one needs to understand the cognitive fatigue brains, poor blood supply, poor glycemic index to the brain could lead to difficulty in getting correct words, difficulty in writing, reading, calculating, difficulty in recalling. So they are interlinked and one needs to understand that. So understanding brain health is important for SLP. In order to understand the recent advances has helped you understand that it's not just alone memory, it's not just alone language, but holistically brain health is studied, the markers are studied in terms of understanding the cognitive communicative health across many researching and the trials which have tried seeing the person as a whole. So there is a vast scope for SLPs to understand what is cognitive health. It's how well you think, how well you memorize, how well you read, learn. Emotional function, the emotional brain health, how well you are able to manipulate your emotions and others' emotions and tackle the depression. Everybody here might have experienced some clinical depression if you have got less marks or flunked in the subject or got very bad scolding from your parent or your teachers have told that your performance is not good, and it could be transient, could lead to days, it could be days and months when there is a loss of person in the family. So many elderlies, when there is a loss of spouse, loss of child, loss of loved ones, might give clinical depression, and the depressed hypoperfused brain can have susceptibility, poor immunity, can lead to stroke incidences, degenerative susceptibility precipitating. So it is important to understand cognitive health, brain health holistically. And tactile functions also in terms of your executive function and proprioceptive functions aiding up to your language. Okay, so one should know the language learning and communication, sensory motor integration. So why research is needed? Because cognitive communicative health is under researched compared to the drugs in the India or abroad. There is less research, that's how we don't have actual great protocols in assessing how aphasia need to be tested in Telugu.
Hello. Sorry to interrupt the session, ma'am. We have left with only 5 minutes to complete the presentation.
I think I have 45 minutes, right? Okay, I have to really... Okay, fine. So, the students here, I have tried making the simple points about why do you promote the brain health is because dementia is on rise. And you know, to ask some questions to yourself about cognitive communicative morbidity. How many people in India have aphasia, apraxia, amnesia, loss of memory, agnosia? And with that, one should know that it will lead to a good research. So let's see what is a thought and a cognition going hand in hand in terms of the dementia research is failing, and that's how you require to do a research in aphasia, dementia, RHD and TBI. And what area you need to really work on? what are the major etiologies presenting with CCD in your population. Next, what you can ask is, do we have valid assessment protocols? And if not, can I develop one? Can I adapt one? What I'm going to adapt, will it be really sensitive in my own population? What is the incidence and prevalence of cognitive communication disorder in mild stroke, moderate stroke, in the person who is bilingual, person who is in 50s, person who is in 60s, person who is in the late 70s. So there is important that we need to have a research questions, okay? We also need to understand each person is different. So cognitive resilience, building, and cognitive reserve. You all know what is cognitive reserve? So cognitive reserve is the ability of your brain reorganizing, tackling, and compensating, coping with any disorder, disease, and cognitively still work for understanding, speaking, remembering, performing, functioning. So everybody's reserve is different for facing the pain, facing the disorder, facing the illness, and still getting back. So it could be different why someone has same brain lesion, same education, same handedness, and they can differently improve on their language, praxis, communicative function with the same therapist giving same therapy and the family members giving same stimulation. And this is what important for you to understand. So you need to understand, explore speech, language, and cognition, and the dynamics of lateralization, collateral pathology, and the importance is your research is the base for this. So there is a huge treatment gap, and how do I carry out my research? You first should have a purpose of the study, then you should have importantly identification of what you want to study, in what population you want to study, then you can try to go for a planning and executing your research in a rightly in acute care or a longitudinal support care where you have a patients somewhere transferred to the rehabilitation setup or academic setup or a clinical setup. So you need to really have a steps of executing your research. I'm sure you have been taught this in RM, but in cognitive communicative world, it will be helpful if you try to understand that literature review in present cognitive communication disorder, and then how we can understand the constraints of Telugu population in rural population or urban developed population versus people who are on the border and their language and communication, and being affected by the stroke or dementia, understood and then well intervened in the early stages versus no intervention, no caregivers to help. So there are importantly researches needed. So I'll skip my few slides and tell you that one should know the search engines and know Boolean operators. So what are the important search engines? I would say Google Scholar, Base, Mesh are important search engines, can help you learn how do I do a research. So if I would say level of evidence, that's very important that you have your research quoting, reference citing from. So RHD, right hemisphere damage, how many SLPs have understood, how many SLPs have assessed, how many SLPs have the protocol, battery developed in India, how many researchers are available from abroad, are there any intervention apps, technology available? So I would say RHD and SLP, RHD, SLP and research, not a therapy. So you can have Boolean operating terms in terms of understanding your research. I have briefly touched upon dementia and PPA as Dr. Goswami sir has already discussed about the dementia. So I would straight go for your assessment. You should know the shrinking brains, the temporal, frontal and parietal lobes are very important, lateralized for your language. So they are eloquent cortex. So eloquent cortex is sensory and motor function, and when there is a damage to the brain, atrophy or lesion, is the person having poor naming, poor reading, writing, tapped in early stage, or it is not been intervened. So one should understand at acute stage what do you ask, what do you test, what do you assess, and shrinking parietal lobes adding to your Alzheimer's pathology. So if it is frontotemporal dementia, it is more of frontotemporal functions getting regressed, versus is it behavioral onset or is it language onset to be known by SLP while you are working with a team of neurorehabilitation, or you are going to bedside to screen someone who is just been referred to you that they have not been communicating as fluently like earlier. So there is need to equip yourself about adequate knowledge about brain behavior, pathology, and clinical anatomy and physiology. Okay. So this is your important role of SLP in CCD, and one should really learn on assessment, therapy, collaboration, but also preventive workup, which is not well explored. You are a brain health advocate, a mental health professional, encouraging your team to take up assessment and rehabilitation in CCD. So you are an important team. You should work and know when you are knowing the major neurocognitive disorder versus minor neurocognitive disorders as per the dementia diagnosis DSM-4 or DSM-5. Okay, so you can have handy tools, simple flashcards, and OPME kit. You can have a quick understanding of aphasia, apraxia, aphasia with apraxia, aphasia with oropharyngeal dysphagia, and the person having poor drive to speak, initiate. So there is abulia or clinical depression, apathy, also adding up to poor cognition and communication. So there are goals of cognitive communicative health are that you need to help person with CCD returning back to society and try to still maintain the quality of life. So the assessment should be therapeutic. So one should know that I should have adequate assessment tools. Okay, so you should have smart goals and smart tools. Okay, so I will straightforward help you understand how do you tap the speech language cognition with a simpler tool and the ICF framework. With Addenbrook's cognition examination, which is an impairment based tool, and it's a simple and detailed screening tool for cognition. You also have a Montreal Cognitive Assessment, MOCA. These both are highly used and sensitive with a good measures of reliability and validity established. In Indian scenario, you have norms available. So ACE-R and ACE-3 both are available in Telugu language, and you have norms. So you can download Addenbrook Cognitive Examination, which has got a language, visual-spatial skills, attention, orientation, executive functions, very well assessed. At bedside, at chairside, you can utilize this tool. It takes 15 to 20 minutes for the normal healthy brains, and it takes 25 to 30 minutes in the pathological aging, stroke, dementia patients. So the verbal tasks are dense, importantly to be taken out when the person has a global aphasia, and then majority of our cognitive tools have language oriented tasks. So one should know non-verbal cognitive tools. Okay, now all SLPs here should test every client with CCD with narrative discourse task. Okay, can I have 5 more minutes? I'll wind up. Yeah.
5 more minutes, ma'am.
Yeah. So please go through the Sydney University Brain Mind Lab, and they have wonderful tools available for assessment and intervention. So SID battery is available in app form also, which can help you understand there's a non-verbal cognitive task which can help you understand if the person cannot understand your verbal command and cannot speak because of the non-fluent aphasia. But he can actually train, you can condition the brain that this is the target and this is the 2 cues, what will you choose? So for sure, the person with global aphasia might be able to choose very well that yes, cat goes with rat. So you are conditioning the brain with 3 examples and later asking the person to choose the right item from the multiple choice available. And with that, you can think of reasoning ability, you can think of verb naming, you can think of noun naming. This is in your mind. So this is semantic cognition. This is a non-verbal semantic association task. So what will go with sickle? Okay, please download this test called ICMR Neurocognitive Toolbox. All the SLPs are entitled and can use the NCTB tool for cognitive and communicative functions across the mild cognitive impairment, moderate cognitive impairment, and this could be helpful for you to understand what are the simple tools available. In Telugu language, you have norms available of the ICT toolbox, and then see what function you want to test. So test of attention, test of language, test of memory. You can be trying to put forward to the researchers and collaborate on rural versus urban norms, or person with right hemisphere damage, or person with acute TBI with mild dysfunction, and see how you can come up with a good research findings and protocols. So your assessment becomes therapeutic. The same task you can add on and make a therapeutic intervention also if you do not have intervention objects with you. So neurorehabilitation requires the etiological, cognitive, communicative, and importantly your ecologically valid protocol. And one should know that you are promoting the auditory cognition, you are promoting the verbal and non-verbal, both cognitive, communicative health. So one should know that adequate amplification is required, adequate testing is required, and see how we can promote healthy ear, healthy brain. And we need to help the person with cognitive communication disorder get adequate support from the family members. So we need to train the caregivers when they can't communicate, they can't understand. So that's where you have to work on your support and advocacy. So there's a quick study what we have done, and we developed a tool for nonfluent aphasia. So verbal DDK, then tap and speak, recall, then match the objects of everyday living, match verbs of everyday living, the reminiscence and validation of the person's old memories from the younger he or she, then middle age, then older age, and we have made this synergistic therapy intervention in PNFA. So it's important that you emphasize on functioning of the brain with all the neurological morbidity, that you have to help the person get equity, accessibility, and the family members should not be somewhere excluding the person. So you need to optimize the World Health Organization and WRF principles for the rehabilitation, and that could be very important that you play an important role in integration of health. Okay, so I will skip the jargon. So medical intervention in CCD, you require to first understand the depression needs to be treated, cognitive stimulant needs to be added, the apathy needs to be worked, and with the medical intervention, the behavioral intervention will give you maximum good result, but no substitute for your behavioral intervention. Okay, so you can use the music, you can use the, importantly, signs, you can use the words, puzzles, Sudoku, apps, technology in terms of CCD, dementia, RHD, MCI, friendly society. And the way forward in cognitive communication disorder, it's you have to improve the spatial, visuospatial, verbal, non-verbal, social cognition, and which is important for your person with any disorder, but he or she needs to return to back to society. So for holistic health, you need to improve the person's holistic health with adequate assessment and the impairment as well as functional testing and rehabilitation. Okay. Yes. Thank you. I'm going to give all the slides with the presenter as well as the PDF of NCTB and the Telugu based test what we have developed in Nizams when I was student and then faculty. So it would be my pleasure if you really use it, and if you have any difficulty, get back to me.
It's a wonderful presentation by Ms. Sonal Madam. Ma'am, I have a question. Is the NCTB tool accessible? Where can we find?
I think this is a slide what I have put it. Search online ICMR and Neurocognitive Toolbox ICMR, and it is You can download the manual, you can download all the test material. It's freely available.
Will it
and
be
it is in
possible
Telugu,
for you
Malayalam,
to-
Kannada, we
Yeah.
don't have Marathi, English, Hindi, and 2 more Indian languages.
Ma'am, will it be possible for you to share to our students
Yes.
and all of us? It will be a great
yes,
help.
we can do that. Yes. It's, yeah. And all these tests are norm developed and norm reference, and then you have a good amount of work, research already happening, so you don't have to again reinvent the wheel. But you can try to work on that, because that's a huge work on our Indian population.
Already blueprint is done, so
Yeah, it's really good that in Telugu language you have it. So test of communication is also just coming. In 2 months you will get test of communication also. So language, memory, attention, visual spatial skills, and quality of life and MCI dementias are well developed. That would be accessible. But if you want to adapt or develop the same tool in some other language, then you'll have to take permission. So you just have to write down to the email to the main author, and they would be happy to help you with permission.
Thank you, ma'am, for giving a complete package of language necessities and assessments and tools for us. And thank you, chairpersons, for chairing the sessions. I would like to ask chairperson to give a token of appreciation to Sonal, ma'am.
Thank you. I hope I didn't make it a buzz talk. I had earlier a lot of slides on evidence-based practice, type 1 research, and I felt the audience were sleeping, so I literally changed my slides. So I hope it was somewhere fruitful, that you will take up a research positively and work on your population. We really need to do research. It's not going to be somewhere burdening, but it should be really challenging and interesting for you.
Thank you for insisting on research, ma'am. I'd like the oral presenters to be prepared, and please come near to the podium so that it can be a little faster. And also I would like to announce the RCI signatures for the day 2. I think some of the students did not sign it. Maybe you have forgotten, but I just wanted to remind you, please sign, because otherwise later if you ask the committee about it, and RCI will not be able to accept it, and we also will not be able to help. Last time 2 times we had some issues with that. So please, I request everyone to please sign without fail. And also please answer the Google forms. So I would like to ask the chairpersons to please accept a token of appreciation from APSLPA. Thank you for chairing the session, ma'am. And Fani sir, thank you for chairing the session. So we'll be going ahead with the oral presentation. There are only Thank you. I would like to call upon Ms. Archita Reddy. Ms. Archita Reddy, oral presenter. She will be presenting on a challenging diagnosis, a case study of mistaken logopedic aphasia. Is it logopenic? Logopenic aphasia as transcortical sensory aphasia. Thank you for introducing something new to me today. And yes, you have 5 minutes. And you want the time? All the best, ma'am.
Good afternoon to each one of you present here. I am Archita Reddy from my Institute of Speech and Hearing. This presentation is being done under the guidance of Mr. Jishchak. So my topic is a challenging diagnosis case study of mistaken logopenic aphasia as transcortical sensory aphasia. So aphasia is a neurogenic language disorder which is resulted due to injury to the brain, typically in the left hemisphere, which affects the core elements of the language network. So what are the aphasia? They have speaking issues, reading issues, writing issues, and understanding issues. So these are general types of aphasia based on the site of lesion and extension of lesion and characteristics. So PPA, primary progressive aphasia, it is a clinical syndrome which is stemming from a neurodegenerative condition which leads to the deterioration of the language network. This degradation affects left hemisphere's frontal, temporal and parietal regions which cause atrophy over the time. So what are the variants of primary progressive aphasia? There are 3 variants of primary progressive aphasia which are logopenic aphasia. These logopenic aphasia variant people exhibit word finding difficulties. They know the word use of the object but they may not tell the word. Semantic variant in which they do not know the meaning. Example of if I say table, they may not know what a table is. So agrammatic variant, in this the person may phrase a sentence but the grammar may be incorrect. Logopenic aphasia, which is alternatively referred to as logopenic progressive aphasia, it is defined by impairment of lexical retrieval and sentence repetition. Unlike other PPA variants, logopenic aphasia is associated with Alzheimer's disease. So lesion in logopenic aphasia is left lateralized temporoparietal, inferior parietal and posterior temporal neurodegeneration. Transcortical sensory aphasia. Lesion in transcortical sensory aphasia is left inferior temporal lobe of the brain near Wernicke's. It is similar to Wernicke's aphasia, but the repetition is spared in transcortical sensory aphasia. So aim of this study is misdiagnosis. As we do WAB, I have done 2 cases. As we do WAB, it is showing as transcortical sensory aphasia, whereas it is a logopenic aphasia. So differentially diagnosing is my topic. So a 60-year-old woman with hypothyroidism presented with cognitive challenges came to the Department of Speech Pathology. She is facing severe language difficulties over 5 years. Gradually worsening symptoms led to the revisit again. So MRI report in 2019 revealed there are lacunar infarcts in the frontal temporal lobes which indicated chronic vascular issues, and subsequent MRI in 2021 confirmed additional infarcts which led to the cerebral and cerebellar atrophy. So detailed case history was taken and WAB was assessed twice in the 50-day period for this patient. So case 2, a 66-year-old female with hypertension, hypothyroidism and diabetes was presented to Department of Speech Pathology. Her neurological reports previously of 2022, she had recurrent cerebrovascular accidents, and initial CV in 2000 caused left hemiplegia and slurred speech, and CVS in 2011 and 2019 led to left middle cerebral artery infarct with right hemiparesis, tremors and motor aphasia. So recent unclear speech and forgetfulness made her to revisit the department. And she was additionally a bilateral hearing aid user. So WAB and FDA was analyzed for this patient. So this case 1 results, this is the initial assessment results, auditory verbal comprehension, repetition, naming and fluency. According to WAB, it comes under transcortical sensory aphasia with severity mild. So when follow-up evaluation was done, auditory verbal comprehension and naming scores remained consistent, but the other two were reduced. But the severity has increased to moderate. So case 2, initial assessment shown auditory verbal comprehension repetition is 10, fluency is 9 and naming is 5.4. It comes under transcortical sensory aphasia in WAB and severity is moderate, which is similar to the previous case. She also had difficulties in swallowing, chewing, drinking, etc. So conclusion is that we need to further develop some other test material also in WAB in Telugu language, which is very difficult for the Telugu patients to be used if it is in English. And PPA should be assessed, which we couldn't do because this is our first case of PPA. So we'll be working on that test. And SLPs should be keenly observing and assess this type of cases. And proper management and differential diagnosis should be done. So this is, as this is a memory issue, it shows the dementia which is of Alzheimer's type. It is very important and it serves as early warning sign for the implementation of dementia treatments. Thank you.
Thank you for being on time, ma'am. Next, I would like to call upon Prasanna ma'am to present on the efficacy of the TrisCare mouth opening device in the management of trismus in patients with recurrent oral cavity carcinoma, a single case presentation. Thank you.
Good afternoon, everyone. Myself Kirti Prasanna Alapati. Today I'm going to present on the efficacy of the TrisCare mouth opening device in a case of recurrent oral cavity carcinoma. So before going into it, trismus just indicates that it's a locked jaw or restricted mouth opening due to tightening or the spasm of the jaw muscles like lateral pterygoid, medial pterygoid, temporalis, masseter, etc., which are innervated by the trigeminal nerve. And the causes include trauma, infection, side effect of any medical treatment, radiation exposure to head and neck cancers, etc. And the common problems because of trismus includes reduced quality of life, inability to eat, inability to speak, and poor oral hygiene. So here I'll be focusing on a single case report which shows a remarkable improvement in mouth opening within a relative short duration using the TrisCare mouth opening device. So the objectives include the assessment of the baseline mouth opening measurement in a patient, to implement the TrisCare mouth opening device for 1 month, and to measure the post-intervention mouth opening in the patient, and to evaluate the change in mouth opening and determine the efficacy of the TrisCare device. And to assess the patient's subjective experience and satisfaction with the TrisCare device. So the methodology includes a 31-year-old male who came to hospital with a wound on the tongue since 20 days, and it is increased in size with time, and post-detailed evaluation it was diagnosed as squamous cell carcinoma of right lateral border of tongue for which the patient underwent right hemiglossectomy, right selective neck dissection levels 1 to 4, and pathological staging revealed T2 and 0 and MET6. So for which the patient was recommended for radiation therapy for 30 fractions. Again in 2023, the patient came with a complaint of pain in the right side of mouth and inability to open mouth, with the diagnosis was carcinoma of right gingivo-buccal sulcus, and the treatment underwent was trismus release followed by right maxillectomy, hemimandibulectomy, right full thickness buccal mucosal graft resection. With reconstruction was done with the pectoralis major myocutaneous flap, split skin graft and tracheostomy on 16th of May 2023. So I have chosen the Triscare device in this particular patient, and these are the different types of devices available for trismus management. So the baseline mouth opening measurement was recorded as 17 mm using the Triscare device. We have the measurement to be calculated on the device itself. So the patient was provided with the Triscare mouth opening device and instructed on its proper use, like to use the lukewarm water, salt water gargling before using the device, which helps in relaxing the muscles in the oral cavity as well. And the patient was instructed to use it like I have chosen. There are two protocols available, like 777 and 5530. 777 indicates that the patient will be holding the device in the oral cavity for 7 seconds and will be repeating it 7 times in a row and will be doing it 7 times in a day. 5530 indicates the patient will be doing it for 5 seconds, 30 seconds they'll be holding, they'll be doing it for 5 reps and they'll be repeating it 5 times a day. As the patient complained of pain for holding it for a longer duration, I had to go up with the 777 protocol. So after 1 month of daily usage, the post-intervention mouth opening will be measured using the same Triscare device. The result indicated that after 1 month of usage, Triscare mouth opening device, the patient's mouth opening improved from 17 mm to 30 mm, which indicated a significant improvement in trismus. Patient subjective feedback and satisfaction with the device was analyzed. Triscare device lies in its patient-centered approach. So it's a non-invasive and patient-controlled method which helps in higher patient compliance and engagement for better outcomes. So the study concluded that the Triscare mouth opening device is effective in improving mouth opening in patients with recurrent oral cavity carcinoma and associated with trismus. Significant improvement from 17 to 30 mm highlights the potential of the device as a non-invasive treatment. These are the limitations and future implications. Smaller sample size, lack of control group are the limitations. Long-term effectiveness and potential recurrence of the trismus after discontinuation has to be evaluated, like for further studies. Larger sample size and longer follow-up periods are warranted for the results. I would like to thank my guru, Mr. Prasanna Hegde, who has been a great support all the time. And I also would like to convey my thanks to my co-author, Ms. Sucharita, and my family and friends who had helped me out. So these are my references. Thank you.
Now I would like to S.A. Ram Shankar, sir, to present a paper on phonological process in younger and older Telugu and Tamil bilingual children. Thank you, sir.
Sure. Good afternoon, all. I'm here to present my research topic on phonological younger and older Telugu Tamil bilingual children. Presenter myself, Ram Shankar, Associate Professor in SRM University, and my guide Dr. Kala Samen, Department of Audiology and SRM University, Chennai. Let's move on to the introduction. So what is phonological process? It's a brief about the patterns of sound errors that are typically developing children that used to simplifying the sounds. So speech language pathology encounter challenges identifying speech sound issues relying on evidence and phonological patterns. Phonological processes are normal in language development involving speech motor growth and linguistic sound errors. So this will be useful for the children to use the phonological system due to the stable and speech ability potentially causing consonant errors. Let's move on to the brief introduction about the Telugu and Tamil phonology. So Tamil phonology features true subapical retroflex consonants and multiple roti consonants. This language has 12 vowels, 5 short and 7 long vowels, and consonants about the 18 consonants, whereas in the Telugu phonology that usually ends with the vowels. This language has 16 vowel, that 8 short and 8 long, and there are 36 consonants, totally 52 phonemes in its phonological system. These are various studies done under the phonological process in Tamil and Telugu and various other Indian languages. Let's move on to the need for the study. In India, children exposed to multiple languages may experience challenges and developing both languages causing speech sound errors. Further research is needed to comprehend the phonological process in bilingual children within the Indian context. These findings will aid speech-language pathologists in designing and assessment intervention program of the bilingual children. So in our study, aims to identify phonological process in children aged 2 years, 6 months to 3 years, 5 months, and 5 years, 6 months to 6 years, 5 months. Move on to the aim of the study. To determine and analyze the types of phonological process in Telugu, Tamil bilingual children in 2.6 to 3.5 and 5.6 to 6.5 years. Moving to the methodology, participant totally we have taken 220 typically developing bilingual children. We have divided in younger and older, younger having 110 and older having 110. And we have recruited the children from the Virudhunagar district, where the people of the Telugu community, 4 decades they have shifted into the Andhra Pradesh to the Tamil Nadu. Data collected from the Anganwadis and the daycares and the pre-primary scale. The tools which are used in the Tamil to assess the phonological process, the word list developed by Dr. Kala and Lalita in the year 2017, and for the Telugu test of articulation and phonology developed by the Vasanta in the year of 1990. To administer to elicit the speech samples by presenting the pre-recorded speech of the both words. Procedure: children sat comfortably in a quiet room and repeated a word from a pre-recorded speech. Prompting was used when needed. Speech samples were recorded and phonetically transcribed by the investigator using the headphones. The analysis, the data organization aimed to classify phonological processes and their frequencies, forming the base for the results and discussion. The results and discussion found totally 24 phonological processes under the syllable structure, substitution and assimilation. Let's move on to the statistical results. We have used an independent t-test sample to compare the younger and older. Coming to the syllable structure, here ephenthesis having a significance in younger and older, whereas in the final consonant deletion, medial consonant deletion, weak syllable deletion, initial consonant deletion having a significance noticed in the older group, whereas cluster reduction doesn't have any significance noticed here. Coming to the substitution process, where backing, fronting, deaffrication and affrication having the significant difference in the younger and older group, whereas in the labialization, stopping and gliding having a significant difference noticed in the younger age group. Palatalization, depalatalization, devoicing doesn't have any significant noticed here. Coming to the assimilation process, significance noticed in the denasalization, velar and nasal assimilation in younger and older, whereas reduplication coalitions having a significance in younger group. Denasalization doesn't have any significance noticed here. So these are totally 24 phonological processes found in the younger age, whereas few disappeared and few not disappeared. So not disappeared around 14 were noticed in the older age group. This has happened due to the language interference, language mixing and phonological distance and socioeconomic background. These are the summary and conclusion. Speech language pathology, phonologists and psycholinguists study the phonological acquisition in young children. Recent research examined phonological growth in children of different ages and languages influenced by the theoretical changes in linguistics impacting the field significantly. It is important to note that phonological errors are a natural part of the bilingual language development and do not necessarily indicate a language disorder. Bilingual individuals can improve their pronunciation skill through targeted practices and exposure to the both languages. In older children, most processes decreased with age, suggesting the development of separate phonological system in bilinguals. This research provided valuable insight for the speech language pathologist in planning and intervention for bilingual children with speech sound challenges. These are my references. I would like to say my thanks in Telugu Tamil. Dhanyavadalu, Nandri.
Thank you so much, sir. So now I would like to call upon Ms. Tania Solanki to present on effect of native language on the sensitivity and specificity of septal peak prominence.
Good afternoon, and one and all present here. The topic of my research is effectiveness. Do I have to change from where I can change the slides? Thank you. So the topic of my research is effective of native language on sensitivity and specificity of septal peak prominence, authored by myself, Tanya Solanki, student of second year MSc AVMC Puducherry, and another co-author is Sindhuja Senthil Kumar, under the guidance of Dr. Amulya Girish. So we all know that a person's voice is very important in the way of they express themselves. Like once you hear anyone's voice, you can make out their identity, gender, emotion, cognitive, social, economic status, level of education, everything. So it means if someone's voice is affected, their quality of life is going to affect. And also it is different variables that one and all use in different languages. So there was one study in 2016 done, and they have also concluded that even if we have same phonatory apparatus, spoken language affects the speaker's voice. So we all are aware of this term vocal nodule. Those are nothing, just a mass on vocal on our vocal folds, which will eventually change our voice quality, low pitch, hoarseness of voice. It will also correlates with vocal nodule. So as an SLP, how it affects us? How can we affected by assessing those patients? Because there will be more background noise, there will be less amount of voice sample you can get from hoarseness of voice those patients, and the air escape due to the glottal chink leading to the aperiodicity of CPP. Here the role comes of CPP. Here it is very advantageous. So what is CPP? I hope everyone is aware of this term. It is a measure of degree of harmony within a voice sample. So if there is a more periodic in a voice signal, the greater will be the degree of harmony, and the greater degree the value of the CPP. Hence the CPP will be greater in normals if we compare to any dysphonic, like here we take as vocal nodule population. So CPP is more prominent in normals and reduced in dysphonics. So this, the need of our study is, again, the benefits and drawbacks of CPP well understood, and it's not widely clinically being used. There are a number of studies which are telling that CPP can diagnose the dysphonic voice if you compare with normals. But there are not such studies. So this study is one of our first of our knowledge, which is telling whether there is any effect of native language on the CPP. So knowledge of the extraneous variables that CPP values can further facilitate in making CPP invaluable tools for both clinical and research applications. So for the same need, the main aim of the study is to compare the effective of native language on sensitivity and CPP, of sensitivity and specificity of CPP. So following, we have two objectives. The one is to compare the values in both the languages, Hindi and Tamil, of two vowels, R, E, and connected speech. The another objective is to compare the diagnostic accuracy of CPP between the two languages, that is Hindi and Tamil, for again vowel R, E, and connected speech. So for the same purpose, we have taken 40 individuals between the age group of 18 to 40, and they were divided into two groups. One was the control group, which consists of 20 members. 10 was Hindi speakers and 10 was Tamil speaker, which were having healthy vocal folds. The another group was experimental group. Again, there were 20 participants. 10 were Hindi speakers and 10 were Tamil speakers who are having vocal nodules. Those patients were taken after the evaluation by otolaryngologists using endoscopy, and the investigators, we were blinded about the results, and the participants were taken from Delhi Hospital, Clinic, and Puducherry. And the inclusion criteria was the participants should not have started at that time they should have not started any speech therapy. And exclusion criteria, they should not have any other problem other than vocal nodules, like any neuro problem, any other laryngeal problem other than vocal nodule. And it is a standard design comparison, convenient, purposeful sampling. These were the details of participants who were included in the study. And the procedure was first we explained the participant about the study, informed consent was taken, and then relevant information was taken from the patient, from the
Your time is up. But it's
okay. Then we have taken care about the background noise, and voice were recorded and analyzed in PRED software. These were the results for healthy vocal folds and vocal volume. Let me just summarize. In these T-tests were performed in that among the healthy vocal folds, there was a significant difference among R and connected speech, but there was no significant difference in E, vowel E. But in vocal nodules, there were no significant difference in E, and healthy vocal folds, there was no significant difference in R. But when we compare the ROC curve analysis, there were no difference in values of connected speech. So hence we conclude that there is an impact of native language on CPP, and researchers have also indicated that voice and unvoiced portion as well as vowels and consonants differ from language to language that can impact the acoustical measures also. So the study is widely interpreted CPP values, and the language needs to be considered while we are interpreting the CPP values, and further studies should be done on larger number of population with more similar kind of population to get better results. And limitation of the study, again the sample size and heterogeneity of the sample. Future study can be done on larger population to get more validated results. Again, I would like to thank our Professor, Dean Director, ND Rajan sir, and my guide Dr. Amulya Girish, and the place where we get data from. Thank you so much for your time.
Thank you, ma'am. And now I would like to call upon again Kirti Prasanna ma'am to present on myofunctional therapy outcomes in facial nerve palsy, grade 4, post-mastoidectomy, a single case study.
Good afternoon once again. So now myofunctional therapy outcomes in facial nerve palsy, grade 4, post-mastoidectomy. It's a single case study again. So facial nerve palsy is a consequence of a lesion of the facial nerve, that is 7th cranial nerve, responsible for innervating 17 pairs of facial muscles, where the damage can lead to unilateral or bilateral, partial or complete immobility of facial muscle depending on the lesion. So here the need of the current study is to specifically explore the rehabilitation of a patient affected with facial palsy as a consequence of otomastoiditis with the help of an early intervention, and to describe the application of different approach for the therapeutic intervention. So aim of the current study is to know the effect of myofunctional therapy for the patient with facial nerve palsy immediately after mastoidectomy, and the objective is to describe the effectiveness of the myofunctional therapy outcomes in a patient diagnosed with facial palsy. So a 27-year-old female who is by profession a teacher has visited the institute with the entry report which reveals that she was diagnosed with right acute suppurative otitis media, and the CT scan revealed right-sided mastoiditis, soft tissue density filling right external auditory canal and prosthetic space. For which she was admitted in the hospital for detailed evaluation and biopsy, and she underwent treatment. Post that she had a complaint of severe pain in the right ear, giddiness, lack of facial movement on right hemiface, difficulty in chewing and intake of few foods. So speech and audiological assessment and speech therapy intervention was performed. The evaluation involved formal assessment of speech and audiology, and the intervention was isotonic and isometric myofunctional exercises. So during the pre-assessment, phonoarticulatory structures, facial expressions were evaluated, and the audiological evaluation was performed, that is PTA. And in this, there was drooping of lips, cheeks and tongue towards the right side of the hemiface, chewing affected, Observed facial expressions in resting position, weak and strong, smile, closed eyes, raised eyebrows and lip movement were affected. And PTA revealed normal hearing loss in the left ear, and right ear revealed mild conductive hearing loss with a prominent ABG gap at lower frequencies. These are the different exercises that were given, and this is the duration that we have given for the patient to do. So the results reveal the goal was to improve the phonoarticulatory structures, improve verbal communication skills, and to improve muscle strengthening, and to sustain the muscle strengthening with an accuracy of each exercise for 3 minutes. And post-therapy, there was drooping of lips, cheeks, and tongue towards the right side of the hemiface has been reduced, and the chewing has been improved. Communication, socialization, and participation of daily activities has been improved, and the muscle strengthening improved. Each exercise duration was improved to 2 minutes 30 seconds. Facial muscle movements and expressions were improved symmetrically. So with the consent from the patient, we could attach these photos post 4 weeks of therapy where the patient showed significant improvements. In particular to weak closed smile, strong open smile, adequacy of stomatognathing functions, and there were presence of acoustic sapedial reflexes. So the study concludes that the satisfactory result was achieved with isotonic and isometric myofunctional exercises for their orofacial musculature and the recovery of facial symmetry in 24 sessions of speech and language therapy. Early intervention, still in the flaccid phase, was of great importance for the patient's recovery. So there's another media in 2015 concluded that patients were showing improvement by using isotonic and isometric myofunctional exercises. Here are my references. Thank you.
Thank you so much. Thank you so much, judges. And with this, we finished our e-posters and oral presentations. So the test results will be announced after the lunch. So before lunch, we just have one last presentation. I would like to call we just have one company presentation. It's called Be Here, Global Speech and Hearing Clinic. Mr. Madhusudan will be presenting a small presentation on his clinic. And before that, I would like to announce all the students to stay for a group picture. All delegates and students and speakers to stay for a group picture. Even yesterday, I think we missed it. And today, it's compulsory that we should submit that picture to the RCI to get the CRE points. So please stay back, at least whoever are present. We could take a group picture and submit it. So you are ready? Morley sir, I'll take out the HDMI. Thank you, students, for your patience. Just a few minutes and then we are done for lunch. After lunch, please come back. We have just 2 speakers who have taken a lot of effort to present what they have learned as their experience to you all. Please share that, and then yes, it's a Sunday for all of us. Let's go back to our work.
Hello. Here it.
You want to see it here also?
Okay, fine. Yeah. Yeah. It's okay, fine. Here I can. Here it is. If it is there, I can. No. It's not changing.
You can use this. He will change the slides and you can use this.
I like to use this.
You want to come there and use it? Because we want it wireless.
Hello. I'll change. You go.
You'll
take
change.
the photos. Yeah. Take the photo. Hello. Yeah, this is Dr. NMS Reddy. I'm MS audiologist and fellow cochlear implants, and also we distributor for Telangana and Andhra Pradesh. So. Yeah, just wanted to ask, how many students are here? Only few. How many interns? It's no one. So practice audiologists? Less than 5 years or up to 2 years audiologists? Please. 5 years experience audiologist here? 1, 2. So more than 5 years, 5 to 10 years? Very good, very good. 10 plus years? Wow, good. See, generally in hearing loss patients, those who comes with the complaint of not able to hear and having the problem with one ear or bilateral, what we recommend? Generally, I'm not hearing anything. What we recommend for the hearing loss patients when come to you as an audiologist after doing the PTA and finding the problem with unilateral or bilateral, you generally required with the hearing aids. Those are conventional hearing aids, right? So in those cases, we'll give the conventional hearing aid. It works with the AC principle. So as we know, like first year students also clearly they have the clarity of air conduction and bone conduction pathway. So air conduction, the pathway is like, sound transmitters from outer ear to middle ear, then cochlea, then alternate to the brain, they will understand. Bone conduction pathway, BC, mastered process. So bone conduction, it signals transmitted in cochlea, then signal goes to brain through auditory nerve and the individual will understand. So where the conventional hearing aid working well, that is okay, and where the individual is having the problem with having the middle ear problems, active conductive pathologies and mixed hearing loss, there we can see the AC thresholds are affected and BC thresholds are still preserved, and having the issues with usage and troubleshooting and repairs with the conventional hearing aid, those cases we have a solution. And in these cases, just before we saw so many audiologists plus 5 years and 5 to 10 years they have raised. And how many, just one question for you, how many cases you have seen outer ear abnormalities like anotia, microtia, atresia, these cases, outer ear and middle ear cases? Anyone? Yeah, 1 or 2, 3, 4, 5. So for them, what kind of hearing aid, what kind of solutions you have till now? Baha, very good. Without doubt, we can say Baha. Baha is the best one. So Baha as again surgical procedure. Next one, yeah. These current surgical implants we have, in that Baha is there, surgical Baha, and Do you have anyone idea about the cost effective of those surgical hearing aids? We have here listed. So button electrode, buttons and metal is having these things. So for them, those who are having the problem with these kind of cases, absence, anosmia, microtia, these cases, without surgery, this first. We have ear new. This is the all first means like Indian product. It's a non-surgical bone conduction hearing aid we have. So the placement of hearing aid is like you can see you can see there. So I have already wear. So TMJ, temporomandibular joint, bilateral temporomandibular joint. We have this kinda. You can just. Okay. Microphone is blocking. Hello. Yeah. So bilateral TMG we are giving the stimulation. So it is transitioning to cochlea. We have this key features. It is programmable. First of all, it is programmable with 5 channels and it is rechargeable. It is rechargeable and we used it Qualcomm noise cancellation technology to reduce the noise also. It is connectivity. It has any Bluetooth, classical Bluetooth devices. It will connect easily and it will stream also directly. Calls, everything. So it has connectivity with your desktops, laptops, even TV also. And it is a sporty look. So someone surgical procedure before visa and basically BCs will be more vibrator. So it is less vibrations. Based upon the thresholds, it has less vibrations and it has lightweight, designly sporty look and it has X6 water, dust and resistance also. So these cases, what we do is TMG to TMG, from one ear to other ear, we'll take the measurements. Some TMG, this right ear to left ear, based upon the child circumference and adult circumference, 24 or 26, it may vary. Based upon the circumference, we'll take the measurements accordingly. We'll go for hearing aid CICs in this custom product. Custom product we have, from since yesterday onwards, so many professions have visited. I have given explaining and you can see stalls. You can visit my stall and you can have a look. You can experience those who didn't still not yet experienced. So for them we have a custom product. So basically we have ear new with good results. BC thresholds are better and AC is getting affected and children's abnormalities of outer ear. Atrasia, anosmia, microtia. These cases we have seen good results and we have fitted in AP Telangana more than 12 plus custom products also. Recently in Vizag also we have fitted. So we are seeing good results. Those who find this kind of cases, please have a look and you can experience, you can give a trial. If it is getting benefited, it definitely prescribes. It has 3 years warranty of the product. Key features are already explained. So this is the one custom product. It's app based. Definitely it's programmable. Programmable with, you can program, you can give the control with parents also, individual also. It has ear new and ear configuration. Ear new will detect the product and it can control. It has the multiple features, indoor, outdoor, and ear configuration once get connected. You can have the program with the left ear, right ear, purely based upon your BC audiogram only, not AC. BC 250, 500, 1K, 2K, 4K. So based upon that, you can configure it like that as AC, what we are doing with our hearing aids. Next. So this is a patent product, we have patent rights. So this is all about hearing. Thank you so much, ma'am, for giving this opportunity.
Thank you for introducing something new, and the technology is nice to know.
Yes, ma'am. Thank you so much.
Thank you, and yes, it's time for lunch. We will meet again in another half an hour.
Patiently listening before lunch.
Yeah, but we'll meet in half an hour. We have 2 speakers and one small announcement by a senior citizen who came up to see all of us. He's an experienced psychologist, and he would like to give a brief about their experience in special children and what the services they are doing for the special children in and around Rajahmundry. So we can have this after lunch. So within half an hour, if we can gather up back here, one small presentation and 2 speakers. And APSLPA life members, I would like to announce the AGB meeting will be there at 4 o'clock. So to get a good quorum and to get an AGB done, so please be present at 4 o'clock so that we can do the general body meeting and end up. And for group photo, yes, we can gather now, ma'am? Just after lunch or now?
So, how many are there in the lunch place? If somebody can give me an idea. 10. 100 are there. So, shall we all have lunch and come back for a group photo? But will people come back? Because I need a group photo for you to get RCI CRE certificate. Otherwise, I cannot do anything. Okay, that is a mandatory thing. So all of you have lunch and please do come back so that immediately after lunch we'll take a group photo. And all those who have not responded to the Google Forms, please do respond. That is a very important aspect. Again, if you don't respond and you don't get points, you're not going to get points. So jitna bhi tumne Google Form responses diya hai, you will get only that many points. So if it is one only you have answered, you will get only 1 point. If you have answered only 2 Google Forms, you will get 2 points. So please remember that attending 2 days and not answering your Google Forms will not help you. Sign in the attendance registers, answer the Google Forms, and please come back for the group photograph. Right? So let's go for lunch, quick lunch, and be assemble here in half an hour.
Run.
Come on, run everyone.
Run and come back. Ma'am, the group photo can be here or...
We'll do it here.
On the stage.
On the stage. We need that banner and geotagging everything. Okay. So we'll do it on the stage.
Group photo will be here only, so please.
All of you please come here. We'll take a group photo here.
Time is
right. Thank you. And we have interesting 2 presentations after this. You should wait for that.
APSLPA life members and members, please understand we need quorum to have the AGB meeting to start. So please.
bookstore pamphlet. Our managers are doctors, two doctors, Dr. Simnarayan Rao and Dr. Anantalakshmi. They have been sparing a lot of time and energies for the sake of development of the Divyangajans 20 years. I have been working with them for the last 20 years also, almost on an honorary basis. So, based on my observations during the last 20 years, and especially during the last 3 years, during the corona incidence and prevalence, I have observed that many problems are caused, multiple disabilities are caused, mainly affecting particularly the speech impairment and speech loss. Based on that, I have produced a small paper. I would like to present you within 3 minutes. I will only take 3 minutes time. Implications of corona incidence and prevalence and the early childhood development. The implications of corona incidence and prevalence during the year 2020 and 2021 and the toddler and early childhood development, manifesting psychological and emotional problems of autism and attention deficit hyperactive syndrome, as well as the speech impairment. They are very significant. The critical developmental stage in the human development is the childhood stage, especially the toddler and early childhood stage, for the crucial development of personality traits of social behavior, emotionality, and communication skills and abilities of the child. During this stage, from 2nd year to 7th year, the child gets awareness of the objects and objective events around him and the environment. This period promotes and facilitates the children for social interactions in the form of interpersonal relations, kith and kin relations, family, group relations, and others, affecting speech and communication abilities and skills. This critical stage needs for the child at the earliest life is the intense, integrated, extensive opportunities for social interactions with close contacts for play activities influenced by various social processes such as imitation, adaptation, assimilation, cooperation, competition, coordination, team spirit, teamwork, and sometimes mild conflict. All these social and psychological processes and interactions were cut off or disappeared, are not provided to the growing children between the ages of 2 years to 7 years of age during corona period of 2020 to 2021 for a long period of about 2 years, which were very crucial for the child for the development of basic and fundamental traits of human personality, such as social behavior, emotionality, such as cool temperament, sweet temperament, emotional stability, concentration, and social behavior with interpersonal relations. All these characters and traits were not developed among the children aged 2 years to 7 years due to the isolation, segregation, loneliness, without peer group, play group, neighborhood group, and social group for social interactions. The children of that age group at that time confined to only four walls inside the home, in isolation, and only to family and that too nuclear families. In these days, when parents do not spare and show much interest and time or adequate time with the children, with close interactions, as the mother is busy with family, domestic and kitchen activities, TV serials, play games, or shouting in the cell phones, whereas father was very busy as a breadwinner with scheduled activities and timing of office. Then the children did not get adequate love and affection, care, protection, warmth, with poor attention for child caring and rearing, resulting into deficiencies and psychological voids of emotionality, leading to childhood temperament in the form of temper tantrums at the first instinct stage to draw the attention, care, warmth, love and affection which were lacking for a long time of 2 years during Corona period, resulted into attention deficit hyperactive disorders as well as the speech impairment that is generally called, of course, as autism and ADHS. The child does not have stability in sitting and activity, in playing total span of attention on a single or a particular aspect or task. He gets waves of ideas in a series of expressions, stimulation and activity. The following are the typical special traits or characteristics of the children suffering from autism and speech loss. The autistic children in general do not have any organic damage. The autistic children are almost healthy and physically fit, doing any overactivity or speedy work. The autism children or speech impairment children have got high level of intelligence at above average and sometimes superior intelligence. The autistic children and speech impaired individuals endowed with sixth sense, sometimes at times expressed as a parapsychological traits and innovation. The treatment to be given to autistic children and impairment children are the following: psychotherapy for the behavior modification by breathing exercises, so-called pranayama, meditation, counseling, guidance, hypnosis, and strong sessions by psychotherapist or psychiatrist, controlling the attention deficit and hyperactive disorder by love-oriented discipline, according to psychologists Jean Piaget, Harvey Keitel, Sigmund Freud, to fill up or make up the void of emotional components of love and affection, care, warmth, and other good childhood relations, child rearing and caring practices with time-bound and task-oriented play activity, with colorful, attractive toys, building block materials, group therapy, family-oriented play activity with colorful, attractive material, parental counseling and guidance, visits to parks, play centers, tourist centers, weekly outings, drawings and painting competitions, kitchen gardening, group problem solving tasks and activities, involvement in helping family and domestic activities, shopping centers, attending meetings, malas, festivals, fairs and other domestic activities like housekeeping, games and sports activities, and attending entertainment programs. Especially in the case of speech impairment, the mothers have to be firstly oriented and trained, and the mother has to follow the activities at home as homework, so that without any break or continuity, continuity of therapies is possible. Only therapy, speech therapy or any other therapy served in the clinics is not sufficient. So this should be continued at home by the mother or family members. Thank you. Thank you very much. Thank you very much. So kind of you.
Thank you, sir. I think you have some full 2 days of scientific session in one of your presentations itself. And he has traveled 2 hours to come here and present his services to all of us. And big round of applause. At this age, 20 years of experience which we are doing now, already done and shown. Thank you so much for sharing, sir.
Wish you all the best.
So now I would like to call upon Mr. Jish Shako, well known as Jish, and the chairpersons for this session will be M. Amulya and Ms. Neha Jain. I would request Ms. M. Amulya and Ms. Neha Jain to chair the session. Dr. G what? Amulya. Oh, somebody wrote in. Dr. G, right? A simple man, Jish Shako, is associated with Ma ENT since 2019. He is not only the head of speech and audiology departments but also the vice principal of BASLP and at Ma Institute of Speech and Hearing. He not only has about 50 national and international publications but also presented as the speaker for various conferences all over India. He has credentials in solution-focused brief therapy for various speech and voice disorders with the exponential growth of ASD cases. He thrives to detect, assess, improve the treatment outcomes thereby on a mission to benefit individuals with ASD and motivate them to conquer the obstacles with I. Thank you, Jishaku. It's all for your presentation.
Good afternoon all. Like for me, most of you are very familiar. I thank APASLP for giving an opportunity to present here. So today my topic is mostly focused on assessment in autism, and this presentation will be more what is happening in AP and Telangana. So I just want to change some like myths what we are following since years and what we have to do or what we have to focus. So please read this. Children are souls to be nurtured, not products to be measured. We always focus that whenever a patient comes to our clinic, first what we do is we will think which test material is to be done, what is the score for that child. We are forgetting that is a child that has a soul, all these things. So this is basic what is autism, like what are the characteristics you will see mostly in children with autism, like social and communication interaction, social imagination and flexibility thought, restricted repetitive interest or activities, restricted repetitive patterns and behaviors, unusual sensory responses. So coming to the number of autism, or like how many patients are there with autism, like according to WHO, in 100, one is autistic. Okay, it's like a not for one country, they have combined many countries together and they came to a picture that in 100 children's newborn, they are having autism. And in US, what is the rate is, as per CDC, they have told that 1 in 36 is having autism. So the sad part is, what you learn in autism in BASLP is not more than 5 to 6 hours. Or what we learn, our knowledge is not going more than 10 hours. But lifelong we are treating or we are coming across these children again. So when we talk about autism, something to authentify is one is DSM and other is ICD. So just the change in DSM 4 to 5. If you see, before it was social impairment, speech communication deficit and language delay. Then we have repetitive behaviors and restricted interests. In DSM 5, they made it like social communication, restricted and fixated interests with expressive language level. So in this presentation, I will be focusing more on what assessments should be done by a speech pathologist for a children with ASD. What is our role in the assessment part? What we have to see. So can anyone tell which test we use if a child with autism comes? Next. This side. ABCCP, then Comdale, then okay. ESA, yeah. So now why the assessment is required from a speech pathologist's view for autism? These are the different points. One is we should know the baseline, then nature and severity of the problem, then appropriate diagnosis, counseling, treatment plan, and predict the prognosis, what improvement you can show. So you told many tests, but are we doing it second part, or primarily what are the tests we have to do? See, these are the what you are learning, or as a speech pathologist, our concept is communication. For communication, what is required? You need phonology, morphology, syntax, semantics, pragmatics. So ABCCP, ISA, all these are secondary. That is only for knowing what is the problem. But as a speech pathologist, or because autism have spectrum, but as a speech pathologist, our work is what? To work on these 5 concepts. Will you agree with me or not? No or yes? But how many of us are doing all this test? Even now I didn't heard any LPT, I didn't heard any other test where you will measure phonology, morphology, syntax, semantics and pragmatics. And with this, one more is, our goal will be like mostly, which is very similar to a behavior therapist. I am not pointing anyone, but what is happening here I am telling. Like we are increasing the attention, we are giving ring tower, all these things. We are not focusing, most of the therapists are not focusing on all this, what we have learned or what we have to do. So I think no need to explain all this. Phonology, you know, morphology, syntax, semantics. So there are many tools. I know this all you would have learned in your second year or in masters, but are we doing it? Are we applying in our clinics? So to know best thing in language, we have LPT. And 90% in Hyderabad, AP, Telangana, it is not available. Is it available with anyone here? One. 2. That means we are not working on it. Then we have language assessment tool, LAT. Then we have 3D LAT. Then COMDEAL. Then assessment development, ALDs. We have many tests where we will get more detail. But we are mostly focused here, you will see, is reels, extended reels. With reels, 1 cars, child is autistic. See, I'll just give a brief about COMDEAL, because this will help you in counseling the parent, and at least you will come to know some idea about the children. So here you have COMDEAL you can use it for 0 to 6 years, and there is 8 domains which will cover, and it is little similar to reels also. You have gross motor skills, fine motor, activities of daily living, receptive language, expressive language, cognitive skills, social skills and emotional skills. So other one is social communication and pragmatic assessment tools. So how many of you are using any of these tools at your clinics? Two. So you have pragmatic profile of everyday communication skills in children, you have pragmatic checklist, then test of pragmatic skills. See, when you see the DSM-5, first thing is social communication is and pragmatic is affected in children with autism. But if we are not able to know which level they are or what is the condition in this, how will we be able to counsel a parent that, okay, your child's communication we are going to improve, we will work on it. It is very difficult. So I'll just brief about one test, that is pragmatic profile of everyday communicative skills in children. So this is like a 5-point rating scale. So in this you have different domains. First one is communicative function. In that you have again 8 division. Then you have response to communication. Like when you are communicating with the child, how the child is responding to you. Then you have interaction and conversation, how the child is during the conversation. Then you have contextual variation, like in different contexts, how the child is interacting or. So that is about pragmatic. Then you have like prerequisites. So if you see most of the clinics, we are still working on prerequisites. Attention, eye contact, eye gaze, sitting tolerance. This is what we are still focusing for any children with hyperactive or ADHD, which should be, see, this is needed, but you can't spend whole 1 month, 2 months, 3 months of therapy for only getting this. It should be only a small part, though this is required, but you can't waste whole clinical time. Next, come to oromotor skills. How many of you are doing oromotor skills assessment separately, or when the child comes to other than CP with autistic? Not CP or in autism, how many are doing? One or more number. So this is one test which is again given by ComDeal for oromotor skill assessment. Maybe more updated ones are there, like there are talk tools or different oral placements which you can more focus, but again this is very easy also. You can do it within 1 to 1.5 hour of complete detailed evaluation. So here you will, it's a questionnaire, you will have again 4 domains and each is 3-point rating scale. You have jaw movements, so where you have almost 6 questions and you can give like how much is the consistency, inconsistency, and whether it is present or not. Then you have tongue movements, then lip movement and speech. So now next part is communication play assessment. All of you tell we have play therapy, we give, like play therapy is something different. Like are we doing some kind of assessment for this? No. How many of you are doing a play, like communication play assessment? 1, 2. I think they are from other state. I am focusing on AP Telangana. Here no, we are not. So there is another again test tool, that is developmental pay scale. So which will tell you the like symbolic play of a child. So which is very useful because you can tell like you can correlate how much is, see when child is born we'll tell they learn through playing or experience. So here you will get the clear picture which level the child is. So these are the different tests for that. This is one developmental play scale. So this also is till 8 years it is available. So start doing. I'll share this. So the summary of this is, if you see, these are what the role of speech pathologists. So first one is phonology, semantic, syntax assessment, then social communication, pragmatic assessment, then communication play assessment, then we have ASC assessment, then PLB assessment, that is pre-linguistic behavior, then parent-child interaction assessment, then oromotor assessment. So these all should be combined in our normal assessment for a child who is coming with autism. So now the question is, can we diagnose a child with autism? Anyone, can we diagnose a child with autism? No. But seeing a child, are you able to diagnose with autism? Few yes, few no. Autism. Seeing the child. No. See. So these are different symptoms, problems, diseases which have like genetic are there, psychological are there. Like one example I'll keep, if there is OCD in a child, everyone know of OCD. OCD main symptom is what? They want to be, they prefer same. Yes or no? Is it one symptom in autism also? Prefer sameness. So you will ask in cars or whatever, you will ask a question, do your child like same color? So what the parent will tell? Yes. They don't want to move around here and there. They want very neat. They prefer particular items. They will focus on that. So a child with OCD and a child with autism, can you differentiate by seeing? No, we can't. And one more question is, can we diagnose, like, can we cure autism? Can we cure autism? Then from where we listen many success stories like, I have cured autism, we are 100% giving curance. There? Louder. Some people are claiming cure. Yes, many are claiming. So till now there is no studies showing that autism was cured anywhere. But yes, like I told you, OCD. If we would have found out that the child is having really OCD, not autism, then it will cure. Or we can modify it. It will be, they will be having a normal living. Like that, many misdiagnoses are getting, like are happening, and what we are doing is we are spoiling the life of many children. See, can screen time leads to autism? Huh? Raise your hands. Can screen time leads to autism? Okay. What is the early diagnosis for autism? Which age you can diagnose the autism? Nine months we can early diagnosis for a autism. But how many of you tell that a child with 9 months use screen time like 5 hours, 4 hours? Or how many children you will see with 9 months or 8 months or 10 months using 5 hours or 10 hours under screen? See, it shows some symptoms. The brain activity will reduce, but you cannot prove that this is autism was only because of screen time. You cannot tell. And one more is, how many of you take parental, like mother's case history when you are doing assessment? Not prenatal, perinatal, postnatal, other things. And how it helps you. Interaction. How many of you ask about nutrition of mother when you are taking a case history? Will malnutrition in mother leads to autism? Or something symptoms, like it can be like any symptoms, any malnutrition during the pregnancy time which is leading to autism. So these are all different. I was telling you different symptoms which will show similar to autism. You can just see which will have somewhere or the other which will show you similarity with autism. But when we are not aware about it, what we do, we will give a broad diagnosis as autism, but it is not autism at all. And here we have many speech language pathologists who give diet. Can we give diet? Many of them I know, they will tell, I told the child, mother, don't give this food, that food. One list they will make, again gluten free, then keto diet, protein high. So maybe 1 month, 1 week it is fine. down the line, are you spoiling the child, or are you, like, we can't tell killing the child, but the child whole life is getting affected with this. Are we aware of that? For everyone, nutrition is required or not? Yes or no? Or not required? So when we are not aware, or nowhere in our subject we have studied anything about nutrition or diet, still we will tell, and each child is different, not same, but still we will focus on diet. We tell gluten diet or whatever it is. But what is happening? The child is becoming malnutrition. Means somewhere vitamin, protein is not going, and which is leading to either lung, kidney or other problem in 2-3 years. And the parent will think it is because of them, but actually the therapist, we are doing it to the child. This is one more I want to, like, when we are talking about food, there is something called pediatric autoimmune neuropsychiatric disorder, which is associated with strep infection. That is called PANDAS. And PANS stands for Pediatric Acute Onset Neuropsychiatric Syndrome. You can read about this later. Okay, this will show you that diet will change symptoms of autism, but it should be diagnosed properly by a known person. See, we give like whatever a diet, but whom we are giving, we will tell any child with autism should go for diet. And this diet, children diagnosed with PANS and PANDAS with diet, they will become normal, who have again autism similarity. So maybe even 100 you have given and 2 children are becoming better or normal, that means it is not autism, but it is PANS and PANDAS. So these things, like, for me, we should never diagnose autism. And it is not like OT, BT, speech, psychologists, no. There are other people also. It should be always a holistic approach. First of all, identifying is very difficult, because we will have 10 minutes to half an hour. You have to take case history, you have to do all the tests, which is very difficult. And no doctor will spend in AP Telangana more than 10 minutes with a parent of child with autism. They will ask for the symptom, they will write autism, and they will send the file to you. But it is our responsibility. We do all our speech tests. We should refer more. There are like some tests like food intolerance. You can go for genetic test, whether it is Fragile X, whatever it is. And it will be always, we will give a positive response to the parent, which will be lifelong, not just for one day. Parents, which will stop that, what you call, window shopping in autism parents. Do you agree with me? Window shopping in autism parents? Every 3 months they will shift one clinic to the other. Why? They are not satisfied anywhere. Why? We are not able to give them a correct answer for what is their problem. Whether it is due to malnutrition of the mother, or psychological problem of the mother, or it is something related to genetic, or it is something else. We are not able to tell. We can tell what you made the child to watch screen for 6 months, that is why child got autism. So this, like, as a speech pathologist, giving diet, then giving other therapy which are not at all in our syllabus or nowhere we are known about it. Even a nutritionist don't have autism in their syllabus. Still we believe that they can give the best diet. No, they cannot give. There should be someone who is specialized, who have very good knowledge. So I think I have spoken more. Any doubt? So thank you everyone for listening patiently this much.
Sir, for emphasizing on what we have missed all this while, and I would like to ask the chairpersons, Dr. G. Amulya ma'am and Neha Jain ma'am, to summarize and thank you.
I would like to Jish sir for
very brief presentation and busting some of the myths related to autism and highlighting what is the exact role of SLPs in the assessment of autism, what are the exact domains that we should be assessing, which includes communication modalities, I mean the components of communication and language. But sir, could you highlight about the term neurodivergent, why it is being used nowadays for these children?
See, actually, there is not one. In this, or normally in autism.
Yes, sir. The term neurodivergent children is being used for children with autism. I mean, what is the rationale?
See, if you see this slide, there are many things like, for example, hyperserotonia, which means like the impulses in the neurons are moving faster. So, which is something related to the neural related. So, there are many neural causes also, which is coming concluded with autism. So again, it is misdiagnosed, we are not able to find out, but see, at the end the problem is at the brain, neural. So, and it is not one, this one, it is a combination of different problems.
Are there any questions from the audience?
Thank you for updating the delegates present over here with the latest assessment tools. I see that couple of professionals are still using reels to do the assessments. So even in our clinical setup, we use ALD, COMDIL, LAT and 3D LAT, but we don't have access to LPT, so we don't do it. But thanks for highlighting the need for assessing social communication and communicative play. I think we'll put that into practice henceforth. And the other thing is, as speech language pathologists, we can identify, we can suspect, because we will be interacting with children with autism in our clinical practice, right? We can identify if something is deviated from the typical developmental milestones, and we can refer them to clinical psychologist. We cannot have mentioned, but we can identify and refer them. So there we play a role. In case if there is no clinical psychologist present in their setup, so they can do MChat as a screener, and they can do ESA, which is freely available, as again informally, not formally.
See, my concept was keep in the parents' mind that your child is autistic, lifelong it is autistic. We are not authorized to do that, or we should not do that.
Yeah, that's what even I'm sharing that. We cannot diagnose, but we can identify by using these tools, and with that observations we can mention and refer them to clinical psychologists who are authorized to do the diagnostic assessment and share. We won't be sharing that the child has autism. Yeah. We say we suspect that the child, or we identify certain features, but to get clear clarification, we would want you consult a clinical psychologist. So that way we can put it. But it was wonderful to sharing this information, so that now we see there's a high the number of children with autism, the number is increasing. So it's very much important to highlight on what tools has to be used and what is our role. And thank you so much.
Hi, Jish. It's a wonderful topic. So I have a small doubt, like if we don't have any clinical psychologist in our clinical setup, as a speech language pathologist, by administering reels, LAT, and we have a right to do ABCCP, I think.
Don't depend only on clinical psychology. Even they are not aware of many of this. Like if you see this, in this they will not be able to tell this is really autism or not. See, one thing we have to think, not now, later also, is a holistic approach where not only medical, non-medical, everyone should be integrated. The approach of treating like homeo, few will tell homeo will work. It's not just homeo alone. All these things, when you mix up and give the child, it will always work.
Okay, yeah, that's my point, Like by administering real SLAT, ESA and ABCCP, can we diagnose it as an autism? We won't diagnose it as an autism.
Here again, why we are not given is, we can tell it is autism based on the symptom.
So usually we write it as autistic features. By query, we write it as an autistic
features. Our focus should be more on speech and language.
Yeah.
We are not labeling any child that you are autistic like that. It can be autism.
Okay, so what provisional diagnosis we give for such kind of kids?
You can go to ICD and ICF.
Okay.
Every 4 years, even 2013 ICD is there. And you have ICD codes, ICD-10. There are different diagnoses, whether it is mixed, receptive and expressive or delayed. We can update it accordingly.
Okay. Yeah.
See, here main thing is we should not give a negative impact to the parent. Here more clinics or wherever, even if a child is not autistic, it is just expressive language delay with 1 or 2 mild symptoms of autism, we are diagnosing them as autism, we are labeling them. After 6 months, 1 year, even they are getting cured. Cured in the sense because it was not autistic. So if you do all the speech tests and we start working on it, it will, within short time, the expressive language delay will be changed also.
Sir, if I may add, can we just put a query autism spectrum disorders?
Query we can do.
Oh.
Yeah. Yes. Yeah, that's what I'm asking you. Can we put query and we can write it as an autism?
Again, the problem is if we see the report, it will be only query autism, which is from a speech clinic, which is not correct. When we are keeping, whether it is below 3 years mixed receptive we can keep, or delayed we can keep, deficit we can keep, or below 3 years normally we focus on developmental delay. It can be anything.
Even you won't mention like secondary too, like that?
No.
Okay. Okay, thank you.
How it influences autism? How autism influences hearing impairment and speech loss? What is the relation between these two?
Sir, without hearing, speech is not possible.
Yeah.
So if we hear only, we will be able to speak.
Okay. Thank you.
How hearing impaired is related to autism? Can you say that? Is that? Yes. Is connecting that. How is hearing aid children will have an autism?
It will be there. Hearing impaired children also are having autism. Even we have done cochlear implant for almost 3 children with autism. But why we did is, see, autism we cannot cure, but at least hearing impairment, which is we take a consent from the patient and we tell them the fact what they will reach also. But when there is a possibility of that, like cochlear implant, we can do that. Because again, it will be interrelated. Children may wear, children may not wear. Some will be hyper, some will be hypo to the sound sensitive. It depends. But see, we have to respect the child. Everyone are human beings. And one more point is like see, if you see a lion in a zoo, how much will be the IQ of a lion? Can anyone tell? How much could be an IQ of a lion which is in the zoo? Not zoo, in the circus. Like which listen to the master, jumps, moves. Anyone? Anyone? Highly intelligent. Actually, it is only 15 IQ. So we are with children whose IQ is like 60, 70, 80, 90, and we consider them as they are nothing, they cannot improve in their life. When a lion in a circus with 10 IQ or 15 IQ can listen to a master, What about these children? More how much wonders they will do if you train them. It is not sixth sense, sir. They are like savants. They have the ability one in more. May not be sense. Senses are always affected. That is why we need it. Yes, sir.
Could somebody pass the microphone to sir?
Yes. There are savants, but again now recently they have removed even Asperger's also. They have removed from the ICD that we cannot diagnose them with Asperger's. Before it was there. Now they have come up with we have to remove it also. So again, that IQ level is just to tell that when we treat a child or when we are seeing them, at least in our mind we should know that how much IQ is there for a lion with 10 can do, and when we see a child with mild or moderate or level, how much more they can develop with conditioning or whatever therapy they can do wonders.
Thank you, sir, for sharing your expertise.
Thank you so much, sir, for enlightening veterinary lion IQs also. I would like to ask the chairpersons to give a token of appreciation to our speaker, Jishako, sir. Chairperson. Yeah, please connect your sir. I would like to ask to please accept the token of appreciation from association. Dr. G. Amulya ma'am and Neha Jain. Thank you ma'am for chairing the session. And Ms. Neha Jain ma'am, thank you for chairing the session.
I would request Mr. Fanindra and Ms. Harika to chair the speech for the next. We have next talk on role of myofunctional chains in our body in relation to speech-language pathology. And here we have our active member of APSLPA will be presenting this topic. Mrs. G. Sri Lakshmi, I would like to welcome on the stage. So here, Sri Lakshmi ma'am have done her master's in audiology and speech language pathology at Bangalore University. She's a myofunctional therapy have done in the year 2013 from Switzerland and Freiburg, Germany. Also, she's an ESSG member of Spain in 2018 to 19, and she have done course from Switzerland, Basel University, and certified in vital stim therapy, also certified in international auditory verbal practice course. Also, she was trained by Dr. Pratibha Kharant in handling children with ASD under DEAL, and she is the founder of Vishaka Speech and Hearing Center since 2007. Also, she is specialized training in the voice therapy in patients with spastic dysphonia and Parkinson's disorders. Also, training in various language disorders like learning disability and aphasia. She is a speech and also have done speech and communication disorders like stuttering, phonological disorders, and delayed speech language. Also, she has presented many projects under like phonological development in children with hearing impairment, comparison of voice parameters in trained and untrained singers and actors, use of EU trainer in children with speech disabilities, worked with cochlear implant patient at Leiden Medical University, Netherlands in the year 2010. In the 2011, started working with Dutch Cleft Klindorg Half DCKH in the German organization who does free surgeries for children with cleft lip and palate. Invited guest lecture in Brent's Spatial Symposium by Basel, Switzerland in the year 2014, 15 and 16. Presented 4 papers over the years on speech language in Brent's Spatial Symposium and Maxillofacial Conference and achieved Best Speaker Award. From these, she started spreading her wings to explore the field in different European countries and showed interest in dysphagia ESSD to an extent to prove endoscopy by speech therapists is a more meaningful assessment for rehabilitation in the year 2017. Head of 6 speech therapy facility cleft centers in India, Hyderabad, Mysore, Bangalore, Patna, Calcutta and Agra in ABMSS, Indian Cleft Organizing, supporting 36 centers in India. We welcome you, ma'am.
Thank you so much, Sucharita, for that elaborative history. Hi, delegates. Yes, you have no choice but to listen to me again, though you're listening from me from past 1.5 days. Yes, I'll try to make it very short. My topic of today's presentation is role of myofunctional chains in the field of speech-language pathology. The importance of muscle fascia. I thought of making it more interactive and lot of tasks and all those things, but then I'll only question and I'll only answer and I'll only do the tasks because I didn't expect these many delegates also at this hour of the scientific session. But then I don't want to test your patience. So before any further delegates number going down, I would like to tell more about muscle fascia. So there's something called muscle, yes, bone. So there's so many doctors who used to ask me, like, Lakshmi, which is stronger, the bone or the muscle? And then I used to say bone, as when I don't know much about muscle. Then they said, no, Lakshmi, it's muscle, which is stronger. Then I started saying, yes, muscle is more stronger because it is connected to the bone and it is connected, is so strong, it is contracted that they will guide the bone. Then they asked again, Lakshmi, which is stronger, muscle or bone or muscle fascia? Then I said, muscle, because I know about muscle. Then they started saying, no, there is something called muscle fascia, which is nothing but connective tissue, which we all call. So this connective tissue is almost like a skin, it seems, which is coming all through our body. Let us talk about this muscle fascia. What is doing to our body? What is the muscle fascia doing to our body? And why is it very important to speech? As student, I always wanted to be approachable to the patient, whoever walks into our clinical centers. And then I used to have this mindset wherein, like, anybody who comes to our center, I need to treat them. I need to show some improvement and then only send. Otherwise, I'm useless. So, and I started getting patients like this. I think many of you also would be having patients like this. Okay. She actually was born normal, but she had some neurological issues, and she started developing strokes and epilepsy, and she suddenly became a cerebral palsy patient. And she turns towards one side and she keeps screaming. Then I asked one of the child, please breathe, and he started breathing like this. Then I come across many children like this who has different kinds of problems other than actual speech and language problems and hearing problems. We get shocked, what is happening to these children? He wants to eat. It's not that he avoided from the beginning. He is accepting, but something going wrong. Then again, yes, he ate, but something went wrong. He finds it very weird. It's very difficult for all of us to get on toes, no? You must be seeing many of you all keep asking me, how can you manage these much heels? Yeah, it is toe walking, which is very difficult for many of us, but they're very good at toe walking. How is it happening? And how to get down with that? Sitting problems, I think many of you face these sitting issues. And even parents come to us after certain days only because they say that speech therapy, how can you manage? My child won't even sit and listen to me only, then how will you manage? So these are the problems we generally see, right? So I started going further and further to find out, like, other than speech and language, what else we can do. Then I thought, okay, why not brain? Brain is the main thing, right? So even today, a few months back, one of the very experienced delegate and speech language pathologist told me, Lakshmi, speech therapy is only speech therapy. You speak and they learn. Speech to speech only is speech therapy. Then I had to understand, speech to speech is speech therapy, meaning you're hearing something, like you're saying some words, animals, lights, and you're asking the child to reply. This goes to the brain. Yeah, I understand. So that means it comes automatically from brain to the mouth. So this is what we are expecting as speech therapy. Yeah, so is it only brain? Okay, let's come to body. There is something called ABA therapy, right? Behavioral therapy. You train the children and tell them that, okay, so I put a sticker of toilet, so this is toilet for you. Whenever you want to go to toilet, behavior trained, you're showing something. So you're doing ABA and brain. So is that enough? We need to do something holistic. We all agree, holistic is the ultimate therapy. So what is holistic? Only brain, meaning the instructions are given and output is delayed. So many a times the parents might be asking you, when will my child be normal, or when can I see the progress? We generally say months or years. We can't just say days like antibiotic tablets or anything. So the moment we say months and years, they'll come and say, years are. Of course, payment is an issue, coming to the clinic is an issue, bringing the child after cooking is an issue. So all these issues can get down in case we do a holistic approach, because we can show progress little better. Otherwise, if we do only brain and body, it will be delayed. So only body, then what happens? Generally, children are trained with behavioral training with one person. Either, if you would have observed, the parent asks, what is your name? He tells very easily. If another person comes and asks, what is your name? Though he knows the answer, he'll not be able to say that. That's because they're trained for that voice, that body, that way of asking their name. So, holistic approach. What is holistic approach? Brain, body, which gives us faster and better responses. So, let's come to body. I'm slowly making you to connect, to say that brain and body is connected, and until we go through this whole process, we might not get permanent results. And why am I doing this, though you know about brain and neurons and body? Because there are so many people who say that myofunctional therapy is body massage or beauty parlor facial exercises and physiotherapy. So the moment you are touching, it's physiotherapy, right? You are pulling the leg, pulling the hand. So it's physio. Why don't you send it to PT, OT, and why are you touching? Yes, we have to understand through the body, then it is easy for you to accept it. So what is brain having? It has many things, of course, gray matter, white matter, neurons. Neurons is the first thing I would like to talk more about. So here I try to arrange a task for you all, but as I told you, I'll do that myself. Think about you're having a smiley ball in your hand. You have to do some function. Your muscles are under function. Then I ask you certain questions. Your favorite color, which is the capital of your country, and things like that. And without the ball, I'm asking. Of course, with your muscle activation in one of your hands, your brain is doing something else. So the answering could be a few seconds delay. Without any of these things, no stress or no other activation, your answers could be little faster. So this is what brain and muscle connection. Yeah, though many a times we think we do multitasking. Yes, many of you think that we are professionals, we are mothers and wives, and also dancers and things like that. We do multitasking, but there are many theories which shows that brain doesn't do multitasking. It gives priorities to particular areas. So when we are doing these tasks, like when I am trying to pressurize a smiley ball, it is prioritizing to the muscle and reducing my brain activity. Yeah, so that way brain keeps on changing the neurons activations. Okay, that's why it is related to the muscle. For example, from past 2 days I made some n number of mistakes. Thank you for forgiving me. Though I'm trying to do multitasking, thinking of the next thing, getting down, and my original actual way of speech, everything has changed. So this is a prime example. We can't do multiple things. We have to prioritize few things. So in that note, I wanted to tell you that neurons will do a lot of tasks, like many of the past speakers also had supported my presentation of neurons are involved in thoughts, memory, learning, feelings, movements, especially balancing and coordination. The moment you start getting on the steps, you need to balance in different way. You are getting down the steps, the same steps, but your balance changes. Then senses, including how the brain interrupts what you see, hear, taste and touch and feel. So body is trying to only balance and do motor activity? No, it is also trying to do sensory activity, right? So it has so many things to do, but at the same time, not multitasking. And here I need to rest everything, sleeping and healing, even digestion, body posture, everything is trained and given from the body only to the brain, right? And also from the brain directly neuron cells are sending messages? No, there are certain chemicals which will be released through the neurons, which are responsible to convey the message of which neuron to stimulate and which to subside. Okay, this is more important here. So this motor and sensory cells are two different things, right? But what are these two different things are ultimately doing? They're taking information, like thoughts and all these things will be there. I'm thinking I need to do this thing, and then sending information to the motor. The moment I pick up these things, then again sending information, yes, the task is done, and getting back to the brain. So these are the chains which will happen from CNS, central nervous system, and PNS. But out of this central nervous system and peripheral nervous system is our favorite, because we need to get information from the body to back to the brain. As many of you also would agree, many children whom we diagnose now or paradiagnosed now as ASDs, they must have been born normal, but later developmental issues and so many issues, they might have changed the things. So the brain central nervous system must be working normal only, but in case the behavior changes, the impulses from body to the brain misfires. That's where the things might go wrong. So that's why peripheral nervous system is more important. So what is motor neurons carrying message away from the brain to rest of the body allows the muscle to move. So we need to be careful that not only the brain thoughts and brain neurons are normal, that doesn't mean automatically we'll be normal. Even our behaviors should be normal, so that we'll get the messages back to them. So what is neuron transmitters? As I told you, it is not directly neuron to neuron. There is something called acetylcholine. As I told you, I see so many people here. I'm happy. Now I feel that, oh, these are my field people. Whatever I'm talking, they will understand. So this kind of relaxation happens in my brain. The moment I see somebody very big or head of the departments, I'll be like, okay, this is very basic, so they might ask a question, or I'm talking nonsense. So these kind of chemicals are the ones which will stress you or pause you as a stop, like, blank. You must have gone blank sometime, no? You don't know what you're doing. So, or relax you. So these, out of many chemicals like oxytocin, acetylcholine is one of the main chemical which will go and trigger the motor activities. For example, catching a ball. Your brain tells a neuron to send an electric signal to the neuromuscular junction synapse, and this causes the neurotransmitter to be released onto your finger muscles so that they contract to catch the ball. So try to understand. I know that you say it's neurons which are sending the current impulses and it's happening. No, it is the chemical which has to release, and that chemical also has to release in particular amount. If at all it is not releasing in particular amount, then again that activation may not happen. So how this synapse changes are happening? These changes in our synapses, like plasticity, right? Whenever I am seeing something, I am closing the eyes like bright light. Then that is recorded. Neuroplasticity happened, you need to blink. Or the moment I see toilet, I wanted to go to a toilet. That means neuroplasticity already released. Okay, as long as we are working out in the clinic, fine, we can hold on. The moment we go home, automatically, we don't sit and say the brain that, you're going home, now you can go to bathroom, now you can put the handbag. No, neuroplasticity sets everything by itself to you all. So the number and size of synapses can change as we use them. As the rest of the speakers also supported this, you use it or lose it, right? So if we use our synapses as lot or more synapses, then that synapse becomes thicker and that becomes a routine and easy movement. If not, there's something called pruning. The neuron immediately tries to reduce its activity, no chemicals, and it starts dying off then and there itself. So acetylcholine released at the neuromuscular junction synapse to cause muscles to contract is not properly removed afterwards, then acetylcholine will continue to bind the muscle receptor. So as I told you, it's a chain. Yeah, you get the thought, you do the job. In case you have done the job, you want to walk, you are walking, but you didn't get information back from the muscle, or proper chemicals did not release, then the muscle and the activity got stuck there. Or you didn't realize that, okay, this activity is over, so I need to go to the next. If you don't even know the next step also, at that step it's paused. So sometimes the muscle is spasmed then and there itself. Okay, one simple example, maybe if it is too much for you all. I sprain my leg on one side. Then what happens, for few days or few months, I'll be compensating on the other side, giving support, relaxation to this side. But don't you think after some time, my whole posture will be changing to the compensatory side? That's what happens that's what happens in cleft lip and palate children as well. When they have these clefts on unilateral right side, what they do is they change their posture towards the left side, thinking that, okay, it's upright. Once it's cleft, then the upper lip goes up. So they feel that the muzzle is up, or they do it the other way. Some of them do it the other way. They try to hide the cleft and they show the other side. So slowly the whole posture changes because of your movements. And no receptors going back to the brain and talking about your normal posture, which you can have. The moment the spine is fine, core is fine, you can have normal posture. But any muscle distraction, or as I told you, the connective tissue which is on top of the muscle distraction cut also can change your complete posture. So coming to the muscle, I hope now you could slowly connect that brain sends information through neurons, through chemicals to the muscle, and muscle needs to send back the information to the brain. So what is muscle doing there? Contracting and relaxing, right? So how is the muscle contracting and relaxing? As we know, the red thing which you are seeing, that only is the muscle. But there is one more layer which is very, very strong. That is what is connective tissue. See, your muscles can be different at different positions. Like here it is thicker, here it is thin. But what about your skin? it's like a cloth covered all through the body, right, from toe to top of the head. So the same way, connective tissue is the one which has covered the whole body. So in case I am stretching or jumping from here and there, like frogs or some of the long jumper sports people, when they do it, it's not the muscle, it is the muscle fascia or the connective tissue which is helping the whole body to stretch. Then the muscles which are connected to the connective tissue are stretching according to it. So this muscle fascia has extreme elastic capacity. Of course animals has more, but in humans also we have extreme stretching capacities. In gym, if anybody goes to gym, many accidents happen because of that. You must have seen whole shoulder joint dislocated and muscles have torn, but the muscle fascia or skin is the one, muscle fascia and the skin is the one which will hold the body. So if we can set the muscle fascia and then the muscle, then things can be normal. This is the capacity of muscle fascia which we need to be very much aware of, and this is the cover of the whole body structure. It's a thin casing of connective tissue. So where is this muscle chain? We are coming straight to the point. Muscle chains is the one which I wanted to introduce to you all today. So why is it chains? I've been telling it's cover, yes, but again it is chains, just to understand that we are moving, right? We are not robots to just stand. So we just cover everything like this, then we can only stand like this. Because this connective tissue is connected to the muscle chains, we are able to move. Like when you're walking, it's alternate, right? Crossing, we are crossing the body. So that is because muscle chains are available. So imagine, okay, the chair is on. So as in when, I'll just tell you an example. When you're trying to sit down, if I ask you to move your hand like this, and ask you to move your foot like this, you can go like this, right? And the same way the other side. But if I ask you the opposite, do the hand to the left and foot to the right. The brain doesn't accept. That is muscle chain. We are chained. We have to follow the chain. If you go opposite and if you ask something else to the body and the brain, it just cannot do so much. So the myofascial chain works in a synergetic fashion. To squat, sit down, we need glutes, hamstrings and quadricep muscles to work together in a coordinated manner. Okay, so connective tissue is the one which is covering the muscle, but these are the muscles which we need to do any kind of movement. The myofascial muscle chain is essential for good posture because it keeps the spine in the right position. So out of all the muscle chains which I will be introducing you, the main thing and what I like is the spine. Okay, there are hard and fast rules. My mentor Suzanne Codoni from Switzerland, she says one simple thing: whenever you see a wrong posture, person walking in a different kinds of posture, like drooping like this or going into side like this, just ask them to put their hands back and right at the hip level and just stand like this. So the moment you put your hands back like this, you become like, why is your trunk getting up? And the moment you put your palms down and sit on this, then again your posture is up. So fortunately, when your posture is up, the trunk is up, I'm happy to take a good breath. The lungs are released. No diaphragm compressing, my stomach will not be compressing the lungs with the diaphragm. So this is the actual spine posture which we need to have, right? So is it only for adults like us to show our good posture? No, children, ultimately, because they are the people who are learning things. And theirs is not, till 7 years, it's not a proper bone also, it's more of cartilage. So changing of those postures even before their fixation of those postures is cruel. We can't accept them to do that. You must have seen many children walking like this. Of course, it's sensory, I agree that, but as I've just showed you how the brain and neuron and everything works, if they fix it like this, even my maid will see and say, Amma, I saw some autistic child. That's how they're becoming. Any feature we regularly see, everybody sees and everybody is diagnosing everybody as autistic. I don't know what future will become. Just because they're changing everything in their body and chemicals. So I'll just introduce very quickly the muscle chains. There's something called spiral orbicular chain, which will help you in getting general balance. Lateral chain, which will help you in getting walking, running and jumping. Posterior sagittal chain, which will help you stabilize the body. Posterior oblique link, which will help you in bending and twisting. Anterior sagittal chain, force transmission between arms and legs and aids the stabilizing of trunk and pelvis. Deep anterior chain, posture maintenance, movement control and injury prevention. Okay, so these are multiple chains. We don't need to go detailed into it, and I didn't even give MCQs on this. Don't worry about it. Don't take anything serious. So focus on how our body. I got only one lady's permission to take a picture like this. I'm sorry. And this is one of the best posture of the cleft lip and palate child I have got. But even in this posture, if you clearly observe, there is a slight compression towards her left and little tilt towards her right. Okay, this is how we generally assess to check how their muscle fascia or connective tissue is bending towards one side and extending towards one side and contracting towards another side. So any contraction of that connective tissue or the muscle is painful, it's stressful. For example, even if your dress is stressing you, even a belt on your waist, it is pushing you inside, then it's stressful. You feel like adjusting this, and then only you will relax and talk to other person. So that's how it is stressful for anybody and everybody. So we need to understand this. Even this little tilts, generally when I was learning this myofunctional therapy, my task was to see everybody around me and see who is having the best posture, and that was like amazing task. Everybody were abnormal only. Never I found a proper good posture. But then, yeah, we need to understand that, see, here we are not saying that the moment the posture is wrong, the speech is gone. No. We are trying to say that release the posture pressures, release the breath, then the speech can be a little more clear, an easy task for them to achieve our speech goals. So, a small video, this is my favorite video, just to simply understand what connective tissue does. Here, she put a dress, like how I was explaining, as a connective tissue to, his name is Jordan, and she compressed one side of the connective tissue. Like any injury, like any accident can happen, and she asked Jordan to lift his hands. Okay, lifting hands we can understand was restricted, but could you see his head? So like yesterday Prakash Bhuminathan sir and some of the speakers also have mentioned, the moment any compression towards your neck position, it could be frontal, back or side or any compression, don't you think speech and the delivery of speech and parameter of speech, everything affects? Yes, so please release the connective tissue. So yes, this I don't need to emphasize more. Connective tissue, our fascia, is related to the forced vital capacity, which is important for us, and phonation and voice loudness and jitter, to maintain the jitter shimmer values. So here I would like to emphasize on voice and speech, because the moment you get a voice disordered child or adult, please check the way how they are sitting and then set them. You will get excellent results. And the moment you set their posture, first of all, they will be more happy. They might ask you like, what is it got to do with, I came for speech therapy, you're not talking about anything, I'm in speech therapy and you're asking me to sit properly, you know. Because they're used to sitting like that from ages. So they won't understand. But the moment you show phonation with their actual posture and the changed posture, the phonation will immediately increase. That can show them in the first session itself. Mind you, the first session itself can show a good result just because you'll set your posture. You don't need to do breathing exercises for 4-5 days and then they say, oh, she's asking me to do breathing exercise, meditation and yoga for 4 days. No, you don't need to go through that. You just change their posture and you'll be set. So this is what is myofunctional therapy which we do. It is always toe to top. Don't think that we go for head, neck, hands, core and then leg. It is toe to top. So whenever anybody talks to you about MFT, MCT, muscle chains or anything, it is toe to top. Okay. So we set the toe. I'm not going very much detail into the protocol of how to do and how to release the muscles. It's just a brief intro about MFT because accepting itself is very difficult nowadays. So muscle fascia responses, this is what we did it for one of the cleft child. She was operated right on time. I think by 3 months she has her lip operated and palate was also operated by 8 months. But still after surgery also the connective tissue did not release. They just connected the muscle. So what is my job? With that mouth, it is little difficult for me to make her pronounce few things or give a very clear speech. So I want her proper lip seal, proper teeth growth, and tongue has to be placed at the parking position. We call alveolar ridge, that is between the frontal teeth, is called parking position for the tongue tip. So tongue always has to be at the tip so that it stays there. It can't be down drooping. Otherwise it won't be rising up for turds or yeah, you all know that. So this is how she was. I hope you can appreciate in that small picture. She started becoming, we gave few myofunctional treatment and her connective tissue has done a very good job because we could catch her early, of course. And then speech was very easy, like a cakewalk for us. Even adults, actually I didn't want to mention that muscle fascia or connective tissue will be working only for children. It works even for adults, but then faster for children, little later for adults. Okay. So for this I need your patience. This video might go little late. I'm emphasizing on this video because this is what is myofunctional therapy. So you remember the child I showed you in the beginning video? Her head was on one side. She screams the moment she sees the physiotherapist, even the place and the voice of the physiotherapist. And when I touched, in the earlier video which I showed, when I touched, that was the first time she came to my clinic. When I touched also, she found it very difficult to move her head and give me the control of her head. So slowly, by doing myofunctional therapy, I could get her neck muscle completely under control, and slowly when I turned her neck muscles, she was very happy and she did not mention anything to me or scream or cry and say no or anything. So if you remember, her legs were on a bow position. Then if you understand this way, if my leg is like this, shall I pull it like this? Or yeah, I need to twist the muzzle a little bit so that it is relaxed. I can't just pull it because it's only bone joint I'm pulling. If at all I twist a little bit, then it is more of my muscle. Muscle is what, or the connective tissue is what I'm releasing, then they can get released. So it is always from toe to top, I need to release their body step by step. And I don't know why I'm not getting the video. Audio of this video. The moment I turned her neck, she started saying That was the best moment for the mother, and mind you, this is my first session. She just came to my clinic and I started doing slowly releasing of the muscle and connective tissue, and first time she started saying very relaxedly without crying. Okay, so that's because ultimately I did it from toe to top. So already she knows I'm touching. Already she's been releasing from toe. No pain, no restriction anywhere. It is just like your shirt or bed mattress or bed sheet. So only one side you always pull. Is it going to set things? No. You pull it from down and set from different corners. Yes. Then automatically rest of the corners will set. Right? So this myofunctional therapy did not work only for her, but rest of the children as well. Who there's one yellow shirt child whom I have showed. He has 1 second. I'll just. Okay, here I was just giving trunk support. Actually, she just had her milk. That's why it was bloating. So immediately I could see that her milk is kicking her lungs up and she's finding it very uncomfortable. So I just gave a slight support and slowly could get into the neck, set her head, and then came to the mouth and made her feel that you need to close the mouth, release the mouth, close the mouth, release the mouth, started stimulating the connective tissue. I'm not going to the muscle, I'm not pulling any cheek or jaw muscle, it's just that skin and muscle tissue which made her release. This is what I wanted to show, from toe to knee and trunk and then the head. So this is the child I showed you earlier. He was doing mouth breathing, and after few classes, I think hardly 2-3, his MPD level has increased to 40. Just because I told him I had to put a depressor small just to get out of that habit, and I asked him to breathe more. And then yes, this child, as you saw, he just puked it out the moment anything goes in. Could be a gag reflex or anything, but the moment we could start giving them MFTs and other techniques. See, these patients are not into only MFT. I didn't do any study or controlled based or uncontrolled based. I've used all the techniques and added MFT so that I could get better progress and better relaxation. And this is the child who did not sit at all, and he started crying and jumping back. And the toe walking was also released. Toe walking was released excellently within days just because of MFT, because their calf muscles are the one which are very tight. The moment you hold it, you can feel it's hard rock. The moment you slowly release the toe tips and then the skin of the calf, then everything will be released. He was also speaking after sitting. So this is it. This is what I wanted to show. The benefits of MFT, we can do therapy either ways. I'm not saying only MFT works, but with and without MFT, there are few benefits. You are connecting to the child more, and it is shorter, as I told you. Progress is more and faster. Yes, the take-home messages. Please remember me whenever you hear about myofunctional therapy, anybody says anywhere. Synapse changes. Though you give a lot of input, as a therapist I'm telling you, go there, sit there, raise your hand, put your leg down, anything. Yes, the synapses do work, but synapses need reverse feeding from the body to the brain. Then only whatever you said is recorded. If not recorded, brain is always a working machine, always. If the brain doesn't work, then it's called maniac, pitchy, they go mad. So how you are diverting the mind to work in a proper track? That is our job, right? The moment you don't do anything useful, you will do unnecessary nonsense things. So brain will keep on functioning. It is up to you to put them in a proper task and then ask the brain to do something, and it will do wonders for you. So muscle movement is important, and long-term potentiation. To get a proper synapse to work for you, for the chemicals to release and potentiality of the muscle. Even at 50s and 60s, some of them are very fit and fine. That's because they have used it. They have made the muscle to use it in such a way. Their movements are in the best ways. And yes, be careful with pruning. Pruning, purposefully I mentioned it in take-home message because though we give treatment to many of our children and put them into regular school interventions also, they come back after 3 months and 6 months or 1 year saying that school is not accepting anymore. He was better, but now he has gone worse. Yes, pruning happens the moment you leave, the child gone to the parent level, then again we are losing our neurons. So be careful, record, make sure the acetylcholine releases, let it record into the brain, then you will get long-term results and faster results. Thank you for your patience. Whatever you do in life will be insignificant, but it is important that you do. Don't leave anything misunderstood. I am there. Ask me questions or take my number. It is there everywhere and anyone has it. I'll be happy to answer you and give you all kinds of articles and references. Thank you all.
So it's a very nice enlightening in the afternoon session. None of the audience were thinking that you will be talking something which is new in our field. So yeah, from the audience. Yeah, please.
It depends on the severity. Sometimes we need
for a normal one.
For a normal person to set into their positions, depends on the age then. Okay, it is like there's something called injury age or changed position age or neuroplasticity happened age. So for that what we have done, there's one experiment I have done. I'm not releasing it yet. I need more time to release that experiment. You must be knowing the pigeon spikes. Every house has pigeon spikes now for pigeons to not come to your house. So I put pigeon spikes onto the wall at different positions like calf here, back here, and at the neck. I fix them onto the wall and I'm trying to ask if at all you want to change your position, I'm asking them to stand like this for 20 minutes. As you all know, the reason of 20-25 minutes for training, 20 minutes is the time because the pulses and neuron system to work till the brain back. Okay, so I give a line to
21 minutes generally.
21 minutes, but but the moment I say 21, everybody might one. Yeah, so I tried to cut short it and make it easy. So I put a line across. They don't come front because the spikes will be poking them. So they can't cross the line and they have to stand like this. The moment they change the posture, immediately the spike will warn them. They're not harmful, they're not very pokey. So that small warning is changing the neuroplasticity of the brain to change their position. So this is what we are trying to see in adults, how they can change their positions. Children it is easy, but adults we are trying to do this way.
I think children only it is difficult now.
Children it is difficult, that's why I am doing it hands-on. Adults I don't need much of hands-on, even see as long as your IQ is good, you can understand why I am putting the spikes and asking you to stand.
We understand but we don't sit for so much time.
Oh, so yeah, adults also I can do MFT and pull the muscle and connective tissue, but it will take time for sure. Children, as you know, fresh. So it is easy for the neuroplasticity and the contraction of the muscle to go on. As you know, see if I injured my ligament for ages ago, then even physiotherapists will say that it will take some time. You know, each muscle, if I understand, each sprain is 3 months to 6 months for adults. Children it is 15 days to 1 month for the muscle. Connective tissue is faster because connective tissue has more strength, and if you observe my slide, I always have this obsession of my theme has to go with my slide. It's almost matted like this slide. Sorry. So it's almost matte, like your cloth. Okay, you won't have any kind of gaps or anything. The moment you stretch something, immediately. So that much strength connective tissue has. So it will repair faster if you pull the connective tissue instead of muscle. Thank you. Thank you for the question. Twice repaired or first?
Yeah, any
Yeah,
like
see, what
during
why
therapeutic
Why
management.
I'm asking is, the moment the surgeon cuts, see the cleft is there,
Yeah.
the moment he has to cut a little muscle,
Okay.
the skin has to be cut to pull the muscle. When the surgeon pulls the muscle, that is the original normal birth muscle, which he'll pull from either sides and slowly he'll stitch like a mat. Then it's very easy for us, because already stretched, I just need to give some sensory stimulation and stretches and it's set by itself. Secondary, what happens, no, already he cut and pulled the muscle, that will be torn off. So my half of the normal natural muscle is toned off again. So when they do secondary, what they do is they stretch the muscle little more tighter. It's like now my shirt is loose. Imagine my shirt is little more tight like this. Then my movements are restricted, and if at all I do this, again it will tear. Okay, so secondary cleft lip and palate repairs are always dangerous because it's more damage to them. We can only promise very little scar reduction. You must be knowing skin scars. Anywhere we get cut. So how is the skin scar happening? You think the muscle is rebirth? No. It's the connective tissue which is forming on top of it. So the moment you reduce the scar, you are giving a path to the muscle to form there. That can happen with the secondary cleft lip and palate. See, that's what, ma'am. See, connective tissue is covering the muscle. Muscle only not there, meaning I lost connective tissue as such, especially in cleft. Okay. If there is no cleft for anybody else, the normal child, I can pull connective tissue elsewhere. Wherever there is a fold, I can release it. In any stretches or any compression, I can release it. But clefts, already no muscle, there is no compromised on connective tissue only. Then I can't bring it from anywhere.
And initially, like you were explaining about the synaptic functions like acetylcholine things and all. So does it happen in other sensory systems also? Like the children who have like olfactory, like other sensory issues, yes, like olfactory, like visual, motor, some like that.
Yeah, unfortunately everything what happens in our brain is because of chemicals only. So acetylcholine happens everywhere to anybody and anything. So depends on how much we stimulus, the chemical will release. If you don't give that stimulus, the chemical is not ready to release. For example, my oxytocin, the moment I eat chocolate, I keep on releasing my oxytocins. So more of chemicals I've released. So I don't it won't be enough to have one chocolate. I might need 2 chocolates. Then only my oxytocin will release. So it's like that. The more you use it, you might get strengthened, but you use it extreme, then you will lose it. So it happens with the rest of them also. But children with our speech disorders and language disorder, they overuse it or underuse it. Communication, they don't want to use it. Repetitive behaviors, they overuse this stimulus. The chemicals are over-releasing. Unnecessarily, the chemical is releasing and it is asking the child to go jump, move around, take these things.
Okay. Yeah, thank you.
Any other?
Yes.
Hemiplegia. And also in cerebral palsy, we find speech without or even without practice, especially in the case of hemiplegia, paraplegia. Whereas in the case of hearing impaired and speech loss, unless there is practice, unless there is exercise and so-called sadhana, they can't recover from the speech loss. What is the difference? Why it happens like that? Without practice, paraplegia, hemiplegia, even sometimes in the case of CP, cerebral palsy also, they recover, even without practice. But whereas in the case of speech loss and hearing impairment and loss, speech loss, we have to have exercise therapy, speech therapy. Unless there is speech therapy, they can't recover. We can't improve them. Why there is difference? I think localization of brain functions. In the case of paralysis, hemiplegia, paraplegia, the neighboring tissue, brain mass, takes the function of the damaged part. Mass action of the brain. Whereas in the case of hearing impairment and speech loss, it can't do. It can't happen. I think so. Yeah. What do you say?
Half correct. Thank you for questioning and answering half of the way. Some CPs, yes sir, I agree. You might correct it as and when you give treatment early, and that too physiotherapist also has to involve in that because it's a muscle thing. But severe CP, no, I don't think they will recover completely, no. So yes, anybody needs practice. It depends on the severity.
Thank you, madam.
So to summarize this talk, now the speech pathologist practice has been expanding. So we were talking about, yesterday we were talking about the dementia where SLPs are entering into the cognitive area to more extent, and speech pathologists also entering into the swallowing to more extent, and I'm sure now we are also entering into the the muzzle, so with which we can see a change in the oral speech communication and the swallowing physiology. So this myofunctional release is one of the technique, and apart from that we also have neurodevelopmental treatment, and we have some other techniques as well. So ultimate goal is like speech pathologist should not only hear the speech and try to manipulate only by the instructions. Is it sometimes we need to touch the muzzle and try to understand the muscular movement and try to help that particular muzzle. And as ma'am said, it is not only this muzzle, it is also the overall muscles. So that what we need to understand. And yes, we are not replacing any role of a physiotherapist in any way. So their role is there. We are just trying to trying to understand and trying to set the muscles with which we can work with our speech to more extent. So you can please correct if I'm anywhere.
Yes, very much correct.
Yeah. So yes, we are not replacing the physiotherapist. Physiotherapists, their goal is to make the child walk, balance. That is their goal. Our goal is to make the child talk, communicate. So this is our goal. But they are also working with the muscles. We are also working with the muscles. But our goals are different. And we need a posture to make the child talk. So they need a posture to make the child walk, child or adult, whatever it is. So yes, this particular topic is definitely much needed in more detail for SLPs who are all interested. So definitely. So it was a very nice talk, ma'am. So all the best for your next talk.
Thank you so much, sir. Yeah. Please don't ignore the muscles.
Thank you so much, ma'am, for enlightening your talk. I also thank for chairing the session, Mr. Fanida sir, and also ma'am. Now I would request Mrs. G. Sri Lakshmi ma'am to facilitate appreciation from the Apaslpa Con. also request Sir and Harika ma'am to be on the stage, also to accept the for chairing the session now. So here I would like to announce the most awaiting prizes for e-posters and oral presentations. So first I will be announcing the oral papers prizes. It's my pleasure to announce that we got it for the title Auditory Stimulatory Maturation Delay. That goes to Stephen Michael J. and the authors are Matthew Nishant, Anusha Rao and Jayalakshmi. I hope Stephen Michael is here. And the second would be oral language pathology paper, phonological process in younger and older Telugu Tamil bilingual children, essay Ram Shankar. Yeah. I would like to request. So, and okay. So, goes to the efficacy of the TrisCare mouth opening device in the management of trismus in patients with recurrent and cavity carcinoma. A single case study goes to Ms. Kirti Prasanna ma'am, Matthew and Sucharita and Kirti Prasanna ma'am, yes, thank you. Thank you for presenting within 5 minutes, Stephen Matthew and ma'am. Announcing the e-posters. The first prize, outcomes based on age of cochlear implant. Mr. Sai Rohit Reddy. Ms. Titiksha Deepanksh, Titiksha and Deepanksh and Amruta Varsha. You all can come to support your team, no problem. Thank you so much, sir. The second prize goes to the topic of initial knowledge and struggle of parents of children with cleft lip and palate. Okay, that's it. That's okay, I understand now. So the speaker is Shaikh Wali Ullar Khadar, maybe, sorry if I'm wrong, and Anand Archana Sathikar. Thank you so much for coming and putting in, make a poster and come and present. Thank you so much. And the third prize goes to Understanding Seizures, Awareness Among the ASLPs and Integrating Primary Seizures Care into the Curriculum. This goes to Abhigna or Abhinay, Shriya, Archana and Gigi. Yes, come on. Yes, you're all already winners in our field, so please. Thank you for making your efforts to make a poster and come here. No, come on, it's okay. Thank you for being so innovative at this age. So here we end the prizes for presentations. So now I would like to call the sponsors. Without you all, yes, this event wouldn't have been so successful. So thank you, sponsors. We would like to thank you on stage. So I would like to ask them to come on stage, take the mementos from APSLP Association. So first I would like to call the company FONAC,
Ramu sir. Yeah. And I would also call upon my Institute of Speech and Hearing for sponsoring us and helping us to get this event successfully carried on. Jish, 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 I think we always have to do this, no? Jish, Jish, Jish. Okay, fine. Yes, Aparna ma'am, for you. Thank you, ma'am. It's always our pleasure. She not only gets a special applause for being a sponsor, but also being a sport. She's like a student. She's like experience. She's RCI. She wants. She's like a mom. Everything. Great. So next we have company RFI and Hearing Solutions. Hearing Solutions, anybody? Please come and take your token of appreciation or the memento. Yes, here's up. Here we are. Thank you, sir. And next we are going to announce Star Key, Gayatri Speech and Hearing Clinic, Mr. Sampath sir, Hari Krishna Reddy, Ashwin Audiology, DB Hearing Solutions, CH Bhaskar sir. Bhaskar sir is there. MedLife, HAC, Devi Speech and Hearing, Trivikram sir, Labat, Sirisha ma'am, Snehil Clinic, Prime Rehab Solutions, Medal, anybody from Medal? Auticon India Private Limited, VK Healthcare System, Auditivo, Teja Speech and Hearing Clinic. Welcome, ma'am. Your extended support. Sampath sir. Let her finish. Medal, yes. Harshita ma'am, thank you so much for your sponsorship and your support by coming here and accepting us. Thank you. Thank you, ma'am. Thank you. Thank you, ma'am. Sampath sir, as usual, he is a very silent person, doesn't like to get appreciated in front. Thank you, sir, Sampath sir, for still being a backbone for all the association. Yes, here we have Kalyan sir from FONAC. Thank you, sir, for your excellent presentation and dance as well in banquet. Thank you, sir. Any from Auticon India or VK Healthcare System, Auditivo, Teja Speech and Hearing Clinic, Durga Prasad sir, is he there? Thank you, sir. No, that's fine. Thank you, sir, for your wonderful support. We are all together like this once in a while, once in a year. And all this happened because of these people who are silently sitting. We hear anybody? It's just there, no? Madhusudan sir. Come on, sir. Thank you, sir, for your support again. Thank you, sir. You can also be here for us. Yes. Signia, anybody please? Ah, there he is. Please come, sir. He doesn't only support financially or get sponsorship, he even puts nails, sellotapes, removes the chairs, places the chairs in the auditorium. And not this time, many a times I've seen that he does that also. So, thank you so much, sir. Thank you, sir. So we have speech and hearing clinics here. I should really say that the speech and hearing clinics who supported us, a great round of applause, because it is your hard-earned money and the intention is you wanted to give it to your field and encourage our field. So thank you for all the speech and hearing clinics. Yes, yes. PCB here. So here we have speech and hearing clinics, Shravya, PCB speech and hearing clinic. Oh, here come from Lalita speech and hearing clinic. Shravanalaya. Shravanalaya is a speech and hearing. It's a clinic. Yeah. Shravanalaya, nice Sanskrit word. Speech and hearing clinic. Vai Devi speech and hearing clinic. Taranya speech and hearing clinic. Swati speech and hearing clinic. Trinity speech and hearing clinic. Prime Rehab Solutions, RK Care Speech and Hearing Clinic, Kadapa Speech and Hearing Clinic, Vijayawada Speech and Hearing Clinic. So many speech and hearing clinics wanted to support this event. I'm so happy to hear about this. Thank you, sir. Thank you so much. Thank you, sir. Thank you, sir. So, Vagdevi Speech and Hearing Clinic, if anybody is there, please come and accept our felicitation and appreciation. Sampath sir as silent as, yeah, unnar. It's good that you have come. We want you to be there. Thank you, sir. Thank you so much for your wonderful support as usual. You have supported us all the time, and thank you so much, ma'am. A great for Sampath sir for his excellent support. As always, silent warrior. Thank you, sir. Thank you so much for that. Now, the man of the event. We would like to see you, sir. We already saw the facilities you have given us, but we want to see the man of the event. From past 2 days, he is working like crazy. Trivikram, sir. And also Surya. And also we would like to call Mr. Surya Narayan, sir, who is also supporting us, and Trivikram sir. And from Vizag, even one call, he accepted us. And he has done the gardening work till the banner and the banquet. Thank you so much for your support locally and making this event successful. Thank you, Trivikram sir. I hope this help will be there further more and more. Shall we come more?
Sure, ma'am. Always welcome.
Thank you. Yes, sir.
Free account, launching in board is free.
Thank you, sir.
Good salary.
Yeah.
Good accommodation.
పని సార్ పని నిన్నంటే ఫెలిసిటేట్ చేస్తారట. Prime Rehab, RK Care, Speech and Hearing, Kadapa Speech and Hearing, Vijayawada Speech and Hearing Clinic.
Trinity Leru.
Yeah. I hope we didn't miss any of them. Phonak, he just came. Ramu. Here, I would like to ask the Presidents and Secretary to say a few words on our event. And, okay, on behalf of them, I would like to say that we are sorry in case of any mistakes and checked your patience by making you wait for so long for so many things. It could be technical issues or any other reason, but it's not. Yes, wanted to give you the best, pleasant and best knowledge to share and get back to your professional field. This is the only intention. But in case any mistakes from our side has happened, it is purely because of the situations, but nothing as personal. Thank you all. And here, if you are interested, there are 2 jobs this experienced professional is trying to announce.
School for Special Education.
You can announce for yourself, sir, in case.
Dear friends, I am very happy to announce that we require 2 speech therapists for the institution running for the last 20 years at Apaslpa School for Special Education of the Disabled Children. We are prepared to pay them a good salary, a fat salary plus free accommodation. Running for the last 20 years. Doctors are running the school. Very interesting place, Koanasima, Apaslpa, Central Delta of East Godavari. There are so many persons worked here, and got jobs in the government services, and they have gone out. So we require 2 speech therapists immediately. Whoever is interested can come and tell their names, willingness, consent. They can come within a few days or within a few weeks. We are prepared to pay good salary, fat salary with free accommodation. If necessary, if needed, boarding and lodging, both our doctors provide. Thank you. Please contact me. Phone number is?
I'll post this in the group.
We will post in our group, sir.
Yeah. Our phone number is, our institution phone number is, our doctor's phone number is 98, please note down, 9849340472. I am repeating, 9849340472. You are welcome. Welcome to Koanasima. Welcome to Apaslpa. Welcome to our Shreya School for Special Education of the Disabled Children.
Thank you, sir.
Yeah, thank you. Please.
Thank you, sir.
Okay, thank you.
Volunteers.
Okay. So before we give a vote of thanks, we would like to call upon our volunteers who worked very hard running up and down. Again, Trivikram sir, Dr. Aparna Ravichandra,
I actually came to thank you.
R. Panindra sir, D. Suryanarayan sir, Sucharita, yes, Sucharita, come on. E-posters and oral presentations were everything taken care by Sucharita. Shalini ma'am, thank you so much for consistently being with me and helping me on stage. Sridhar Raju sir, dancing somewhere? No. Thank you Sridhar Raju sir for supporting us technically and also for e-posters and oral presentations.
Gautami.
Thank you Gautami ma'am.
Harish.
Okay. B. Harish sir, P. Murli sir and Archana.
Archana Shastrikar.
Archana Shastrikar. I want to see Archana Shastrikar. So please come on stage, ma'am. Thank you so much. The whole volunteers are here. Shalini, Sucharita, Trivikram, please be there. Oh, okay. Okay, one by one. One by one.
నా ఫోటోలో ఎక్కువ ఉంటాయి దీంట్లో చేస్తే
కావాలి రోజు దేవుని చూసినట్టు చూస్తే కొంచెం పుణ్యమైన వస్తుంది.
అంత వద్దులే
కొంచెం జ్ఞానమైన వస్తుంది.
గోపి
శ్రీదశ కమాన్. కారం జీబీ ఉందా లేదా అనౌన్స్ చేయాలా? ఉన్నారా?
సరే దానికన్నా ముందు నేను ఒక థ్యాంక్స్ Okay, so good evening to all of you. I know this is the last segment. I would like AP Association, AP Audiology Speech Language Pathology Association, coming forward, collaborating with us, giving my Institute of Speech and Hearing an opportunity to work along with them. It was really a wonderful job. We were working on it since last 3 months. I really see their dedication, the way they work, and everything in a very coordinated manner. I thank you all for collaborating with us, and I thank you all for taking care of us so well. And I congratulate all my students for a wonderful job that they have done. And last but not the least, see you all again next year. Bye-bye.
Thank you, ma'am. Thank you for inspiring us and expecting us to come back again next year.
Lakshmi madam.
Nenu
Yeah, now for Lakshmi ma'am. Come on, all of you. Give a big round of applause to Lakshmi for taking us through these 2 days in a wonderful manner. So all the credit goes to her to make this whole function go on in a very smooth manner. Whatever technical hitches are there, she takes care that nobody is pained. Everybody smoothly enjoys, and yesterday we had great fun in between all those issues that we were having.
Fanindra sir, I would like to say a few words. Something and he says why you need it. Then ultimately he gives it to me. Thank you so much, sir, for this wonderful event for us. Yeah, I would like to ask the presidents and secretary there on stage, so that the audience can thank you and you can thank the audience as well. They have come all the way out of their comfortable zones, trusting us and seeing us here to share the knowledge and know about what we do in other places. So Presidents and Secretary of APSLPA, please stand and thank the audience.
I thank management of my Institute of Speech and Hearing for associating with us. Of my institute, I thank everyone, and I thank all the delegates and students who came along with here and being here and participating in this conference. I thank each and everyone, and I thank all the supporting sponsors. I thank each and everyone. Okay, thank you. Bye. Sujita Garu, volunteer. I'd like to ask Sujita Garu please to come on the dais to take. voluntary
RCI, CRE points, if
points
anybody,
registration.
Sujit only will get all these CRE points. Thank you, ma'am, for consistently being at the register counter and encouraging the students. Please come. Thank you. GB. Okay, yes, we have come to the last part of our event. We are going to have a small GB meeting of APSLPA. I would request all the APSLPA members to stay back, and yes, rest of the delegates, thank you so much for coming, and the day ended. Thank you all. I hope you will all go safe to your places back again and start your work again from Monday. Thank you all.
Excuse me, please hold on. Please hold on.
ఇప్పుడు ప్లే చేయగలరా?
We'll only sing, ma'am. Ma'am. We'll sing. Please stand up. We'll have a national anthem now. And the day after tomorrow, we have an Independence Day. All of you, happy Independence Day in advance. We start national anthem together. All. Jana Gana Mana Diya Hai Bharat Data Punjab Sindhu Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchchala Jaladi Taranga Tava Shubha Name Jage Tava Shubhashish Mage Gaye Tava Jaya Gata Jana Gana Mangala Dayaka Jaya He Bharata Bhagya Vidata Jaya He Jaya He Jaya He Jaya 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 He Jai Hind. Bolo Bharat Mata ki
E-posters, you can collect certificate at the counter, registration counter. Oral presentations also. Sucharita, oral presentations also. Oral and e-posters, please collect your certificates before. Thank you. GB meeting is on. I would request all the life members to stay back. Yeah, please.
Ma'am, quorum kada ma'am? QU? CH. నాకు తెలియదు